Okay. Dzień dobry. Good morning, everyone. I'm Roberto Takaoka. Is there an echo? I'm the Vice President of ISED. It's a great pleasure to be here in Gdańsk, in this beautiful city. And we're going to start this session about organization of care in atopic dermatitis. And I would like to introduce Professor Jean-François Stalder. We're going to moderate this session together. So, Jean-François.
Thank you, Roberto. We accepted to manage this session because I think it's very important to have a session dedicated to patients. It is probably one of the fourth experience. The first one was in Kyoto, I think so. And today I wish to have a time for sharing and discussing and to obtain creative thinking about the role of patients and the role of healthcare provider. So Roberto, you would like to maybe introduce Magdalena?
Okay, we'll start the first module, which Magdalena Czeziak will go into introduce this first session. And of course, you know Magdalena is the general chair of this meeting, so thank you for having us here in your beautiful city.
Thank you for invitation here for this wonderful session about the solidarity in patient education. So it's honor for me to welcome you for this pre-meeting session. And thank you for pronouncing my name in such a beautiful, wonderful Polish way. Okay, so I wouldn't like to prolong, so it's my great pleasure to invite Joanna Małaczyńska-Ręczlaj for the first lecture about patient therapeutic education in Poland. Patient view. Good morning. Yes, here it is. Good morning. My name is Joanna Małaczyńska-Ręczlaj. It's hard to pronounce it in English. I would like to talk about a system of support of patients suffering from atopic dermatitis in Poland in the field of health education. Maybe I will introduce myself. Thank you for inviting me here. Atopic dermatitis has been with me since childhood, but not as a patient, but as a doctor's daughter. A doctor whose passion was atopic dermatitis. And as a child, when I spent a lot of time in hospital with my mother, I was telling myself that I would never be a doctor because I don't want to spend so much time at work, and I didn't. But after years and speaking so much with patients with atopic dermatitis and some other, I decided and I joined a foundation focused on problems of families affected by atopic dermatitis. And now my daughter is sitting with me in my office and telling to me that she will be a doctor like her grandmother and take care of atopic dermatitis. So maybe it's our family destination to take care of the subject. Our foundation is the only one and the oldest one foundation in Poland focused on atopic dermatitis. It was established in 2011
And since the beginning, we run the rehabilitation center dedicated mainly the patient with atopic dermatitis. We combine education, sport, and rehabilitation in brine pools in Sopot, so near to Gdańsk. Why we are doing it? We know that atopic dermatitis is not only a disease, but also it's a huge social problem. When we speak with patients or the family, we can realize that they have a huge problem with performance of daily activities, with absences from work and school, with reduction of physical activity, with depression affecting about half of sufferers, disturbed family relations. I love that when I speak to parents of children, when they told me that, okay, you know, the grandmother knows better. So they send children, their child to grandmother, and she knows better, she knows better than doctors, and after a few days, child is coming back with all the symptoms and in not good condition, skin is not in good condition. We have lack of understanding among teachers and bosses, and very expensive treatment. It can happen that the treatment costs almost half of the lowest salary in Poland. It can cost so much. So we in Poland, there's almost no refunded emollients. So the people really have a great cost of treatment. And one of the problem is also the long waiting time for medical appointments. Why? We have increasing number of patients. So about 1 million children, so 10–15% of children in Poland suffering from atopic dermatitis, and about 500,000 of adults. The public health system is not efficient enough to deal with this problem. Unfortunately, we have also decreasing number of doctors. The average age of specialists is about 50, so it's hard to find the good solution between increasing and decreasing number. So we have approximately 1,500 allergy specialists and 2,500 dermatology specialist patients. Very often go to allergist or dermatologist or to the both. We have also the average number of visits in public system should be about 4–6 visits per year. So because of those low number of specialists, very often patients are going to general doctors. Here the numbers are a bit better because we have something about 15,000 pediatric general doctors and the same number of internists. But they are not specialists. Of course, they can help in the first with first problems, but they are not specialists. So I've checked a few days ago the average time for appointment in our voivodeship, so in Pomorskie, it's about 60 days. But if you have problem and you need now, you need help now, 60 days it can be too much. and also what's expected by National Health Fund, its average time of the visit 10-15 minutes. For sure you all know that 10 or 15 minutes for atopic dermatitis patient, it can be too short time. So from the patient point of view, for the patient organization point of view, what we think it should be done. In accordance with the guidelines of the Polish Society of Allergology and Dermatology, its health education is extremely, extremely important. It's also important in media, but we have, 10 years ago when I started, or even more, it was very hard to involve media to educational campaign because atopic dermatitis is not media. It's not media disease. It's hard to show how people are suffering. They have hands, they have legs, so it's not disability. It's only skin. So how to show it in media? During the last 10 years, something bit has changed, but for sure it can be much, much better. We think that needs and problems of patients could and should be addressed by patients' organization. There are few patients' organizations in Poland now, and it should be, the patients' organization should be a partner in search of systemic solution. One of the best places for patients to learn about their disease is to attend atopy schools. I'm very happy that we meet in Gdańsk, in my city, in City of Solidarity. A few important historical moments started here, and also in 2005, the first atopy school, established mainly by my mother, who started in Gdańsk, in Poland. A few years ago, online atopy school established by Professor Trzeciak was online, so very dedicated to very wide part of the patients was established. In atopy school, there are a few more atopy schools in Poland, yes, but we are the first ones. The atopy schools should educate patients and their families, maybe teachers, not only how to manage the disease, but also related problems. However, all those atopy schools are incidental action, not systemic ones. The objective of atopy school is to reduce time of the first visit, so patient just to that 15 minutes which I was talking about, fewer hospitalizations, fewer medical interventions, improve quality of life, and reduce treatment costs. According to our data, patients expect atopy schools to include advice from a dermatologist, allergist, dietitians, psychologist, and nurse. So, I should finish, but how we can contribute and work better together. I think, and answering the question, is there a system in Poland? No, it isn't. No, there isn't. Yet, but we are in Gdańsk, the City of Solidarity. I think that we are on the right track, and in few years' time, maybe we'll meet one more time. There will be a system. Now we have many people who want to create the system and to create a roadmap for patients and their families just from the very moment of diagnosis. that roadmap should address patients' problems and their needs, so they are not left alone with the disease, and very often it is now. And that health system and specialists will not have all the time to address all needs and problems. So support activities from NGOs should be filled the gap. And the most important thing is to try to open the doors of opportunity for patients, because atopic dermatitis is not just a one-dimensional disease. It's a multi-level problem, and we all, patients and doctors, should work just to improve patients' lives. Thank you very much.
Okay, so we had a moment to hear about the patient organization view for the patient education in Poland, and now it's my pleasure to say some words from the healthcare professional, how it looks. When I thought about this topic, what is the therapeutic patient education for me, I thought that we cover some aspect. So of course, first of all, we need the personnel, we need the staff, and of course there are many fields to be covered, like of course AD in the causes, burden, diagnostic and treatment, but also people who just deal with the patient. And of course the third point is are the tools. Who treats AD patient in Poland? Mainly, as you see here, dermatologists, but also we are supported by allergists and GP doctors. Another question is how many dermatologists we have. So according to the information, the newest one, we have like 2,642 dermatologists and 1,483 allergists. But you can imagine that we have 37 millions of Poles. So it means that we have more or less 100 patients per one dermatologist regarding the number of AD patients suffering from atopic dermatitis. With education, we have some challenges. We have no officially TPE-treated nurses, and TPE is not reimbursed in our country. So we try to find a way how to face these challenges, especially that we have really broad field of education to be covered. And as you see here, 75% of patients believe that they have not received answers to important questions related to their disease. Maybe, of course, it's the point that the time of the visit in specialist is really short, because what can we do in 10-15 minutes regarding the whole examination process, history of the patient, and so on and so on. So, and we have some studies made by my PhD colleague who just show us that, please see, even 55% of adults suffering from atopic dermatitis and 50% of caregivers of children suffering from atopic dermatitis have not received the information how to use emollients, the basic treatment of atopic dermatitis. So, and another question and another answer, do we really need therapeutic patient education in Poland? And as you see here, 75% of caregivers and 75% of patients suffering from atopic dermatitis, they really need education. 3 out of 4 AD patients. So these are studies made by Mikołaj Cichoń, and we really realized how huge is this problem. Of course, we have another challenges like corticophobia, which is very well known fact. Professor Stadler is the leader with this topic. But also we checked what about other anti-inflammatory topical drugs like calcineurin inhibitors. So you see here how long do we treat with calcineurin inhibitors with proactive therapy. You see as short as possible, and the patient fear about calcineurin inhibitors. So of course there are much more fields to be covered with the treatment. We now in the era of new treatment biologics, and there is the education need for the patient and the message from us. So of course we are much more aspect of atopic dermatitis which are included in the education process. So what can we do? Of course, in Poland we have the patient organization. One of them you know now very, very well. It was established in 2011, but the history of Atopy School is a little bit longer. It started in 2007, but we have also another organization, one which was created by Professor Kowalski in Łódź. This is the Association for Asthma Patient and Allergic Patient Foundation, and it was established in 1994. But nowadays we have also the coalition of healthcare professionals working with patients, and one of them, and the first one is Coalition for Asthma, and we will talk in the round table about it more in details, and the other one is dedicated to atopic dermatitis. This will be also the subject in our round table. Of course, TPE is therapeutic patient education, but it's also, I would say, therapeutic pharmacist education, because of course we cannot treat as sufficiently as we would like if we do not cooperate with pharmacists. So we try to educate our colleagues during the congresses and training courses. Of course, we have quite new tools like application. So the need amongst the patient to use the application is like even 80%. Of course, there are a reliable source of information. And what is the most desirable for the patient? This is, of course, tracking time of steroid use, again steroids, and reminding to take or to use the emollient or the treatment. And of course, what would be nice for the patient, these are tips how to alleviate the itch and the flare-up calendar. Maybe it's something interesting for developing new tools. And how we perform? Of course, we try to educate our patient, creating the websites, and this is the team of my colleagues and students who works with me just to provide the proper information to the patient. And we have prepared the guidebooks for children, like a fairy tale, to understand that the emollient use is something normal, like brushing your teeth, or for the adults and for caregivers. So it's everything possible to be uploaded and spread for the patient in the paper format. And the Atopy School, which were mentioned, of course, we have a long history in Gdańsk here with the Atopy School, in Hospital of Polanki, in our Medical University of Gdańsk, in the Department of Dermatology, Venerology, and Allergy. There are also Atopy School in Łódź and in Zabrze. And these are my colleagues who helped me with this online Atopy School, especially in pandemic time. It was quite good solution, but still we continue because it's also very comfortable for the patient. So just to finalize, I would like to summarize this, that of course this is our Gdańsk initiative, multi-speciality approach to the solidarity in TP, and of course we work as a dermatologist, we work together with pediatrician, allergist, gastroenterologist. These are our colleagues who support us during the education in atopy schools, and of course with the patient organization and psychologists. So we have many colleagues for cooperation, and of course we have the place for you if you would like to join us, especially in this online. There is no problem. So thank you very much for your attention. And to continue this topic, I would be honored and I'm delighted to invite my colleagues for the round table, and we will be happy to take your question if there are any. And my pleasure is to invite here the president of Polish Society of Dermatology, Professor Jacek Szepietowski, to join us. And I am also honored to invite Professor Maciej Kupczyk, the president of Polish Society of Allergology, and for our roundtable. And I'm honored to invite on the stage the head of the Department of Dermatology, Venerology, and Allergology of Medical University of Gdańsk, Professor Roman Nowicki. And I would like also the team to provide us with one more chair. Yeah? Oh, okay. No. So, yes, we would like to ask you for another chair. So are there maybe any question from the audience? If not, so I just told you that I would like to continue with this coalition on atopic dermatitis and on asthma. So if you don't mind, I would ask the first question to Professor Maciej Kupczyk, because he's one of the leader of coalition for asthma, to share with us his experiences, because we know that AD and asthma nearly always walk together, and we very often learn from each other. Yeah, you can use this one. Yes, of course.
Thank you. Ladies and gentlemen, let me start with congratulations to Magda. You know that you are the best, and thank you for inviting us to this great meeting in Gdańsk. And of course, in regards of education in atopic dermatitis, this is a huge effort and a very important topic which is heavily underestimated in generally, I would say. What is the main bottleneck? I would define that this is not reimbursed by our public payer. Yeah, neither in regards of any kind of courses, training for patients, even not the education given by nurses. Yeah, so what you presented is an effort of patient groups and an effort of you as a doctors who are taking care on patients. And of course, this is a huge problem, and it's not easy to solve it. I think this is not only in Poland that is underestimated. That's not only in Poland that is not reimbursed. Yeah, this is a global issue, a global Poland. And actually, education is a key in all kinds of chronic diseases. That's not only the problem of atopic dermatitis. And Magda asked me to give you a few words about the coalition for asthma. We can say more about asthma because this coalition has been established already a few years ago. And I think that was a huge success. The coalition is different from society. The society is a platform that we all, I mean doctors, join. But the coalition is a platform when we cooperate in regards of different societies, including, for example, Polish Society of Allergology and Lung Diseases, patients organization, which is key here, yeah, in this kind of effort, but also pharma companies, also universities. So we combine different points of view, and we are able to solve problems. Why? When we launched the Coalition for Asthma, we defined a stepwise approach. So first, we started with a report on the current situation. Yeah, what's the problem with asthma in Poland? Of course, this is an example, and I think the same can be done in atopic dermatitis. So this report summarized the epidemiological data, pharmacoeconomy data, the burden for payer, what are unsolved, unmet needs in the disease. It was followed by the next report, which presented the patient point of view. So patients presented their ideas. What is the real problem from their point of view? And I think we were shocked, I must tell you. I don't have time to go more into details, but that was shocking. What is interesting, it was followed by doctor's view, especially in regards to the access of, for example, biological treatment for the most severe patients, etc., etc. And again, we were shocked that even if we ask specialists, they are not all aware what should be done with those patients. So there is education not only for patients, but there is a need for education also for specialists even, not talking about GPs, if we want to think about referral. And then the next step, because just a few days I received the report for HTA, so Health Technology Assessment Agency, trying to define those bottlenecks in regards of the reimbursement or any kind of public financing in this disease. And I think and I hope those 4 documents will enable us to address those aspects in regards of both education and in regards of the public payer, how we should address, what we should present to our Ministry of Health, how we could improve the care in the particular disease to diminish the burden of the disease, both for patients, for their families, but also for the society and for the public payer. So I think this is the stepwise approach that can be successful.
Thank you very much. This is really the complex problem. And now I would like to transfer this question to Professor Nowicki as a leader of the coalition for atopic dermatitis, how we just face this in our country. What is your point of view or what we would like to share with our colleagues?
Thank you very much. It's a great pleasure to meet you in our city. This city not only solidarity, but this is special city for atopic dermatitis, for love, and for many guests from many countries. Atopic dermatitis is a big problem, but for happiness, more our patients are only mild atopic dermatitis. Of course, we have all patients who want biologic therapy, but the first step is the basic therapy and very good cooperation with parents, with caregivers, with another doctors. It's a big problem, then our patients at first go to general practitioners. And general practitioners have many drugs for atopic dermatitis, but not always good. This is very lack of information. The information and special courses for nurses, for general practitioners is very important. We have every year special meeting in Gdynia. This is new harbor by the Gdańsk. Every year in the February we meet with general practitioners, pediatricians, allergologists, like our president, and sometimes comes to our president of dermatology too, and we discuss about the best emollients and best practice for our children. Welcome in Gdańsk. My name is more simple there my colleagues Magda Trzeciak, my name is Nowicki, like no whiskey. I wish you good stay in Gdańsk. Do you know that today in Poland is Day of Solidarity? Have a good time in our city.
Okay. Thank you so much, Professor. And of course, the last person which I would like to address my question is Professor Jacek Szczepetowski, last but of course not least, and he has a general view as our president of Polish Society of Dermatology, how looks the education in Poland, maybe more broadly than only from the point of view from Gdańsk. So please.
Thank you, Magda, for the organization of this meeting. Congrats. We are so happy just to get so many colleagues from all over the world in Gdańsk, in Poland. Of course, I do believe that this pre-meeting symposium is of great importance. Experience from different countries concerning the taking care of atopic dermatitis patients. And I think that's a really complex problem, and we should discuss this as health professionals, and also we should discuss being patient-centric. And first of all, I would like just to refer to Professor Nowicki talk, and I think that the cooperation between different specializations is of great importance, because as it has already been said, especially if there is a child with atopic dermatitis, the parents are going to different doctors. They are going to dermatologists, they are frequently going to the pediatricians, to the general practitioners, to the allergologists. And they are receiving really just different advices for the taking care of the skin of the child, and we should work together to have the common language, because we have some differences in our opinions, even concerning the bathing and so on. And I think that we did the first step, and that's because of Roman as well, that the Polish Dermatological Society, together with other societies dealing with atopic dermatitis, like the Polish Society of Allergologists, general practitioners, pediatricians, we created the guidelines how to manage the atopic dermatitis. These guidelines was signed by all the societies. This is the first step. Of course, there's only the document, but we should spread this knowledge to the regional dermatologists, allergologists, pediatricians, just to be quite familiar with the guidelines, and to give similar, at least similar, I'm not saying exactly the same advices to the parents, to the patients, because the patients are lost. I have nothing against that the parents are seeking the best for their children. So they are going to one doctor that like just to have a better treatment. That means they are changing the doctor. There is a doctor shopping just system, and we are not able just to stop it, but we can just work with it, giving just at least similar advices. So this is the first comment from my side. The second comment is that we need just to work with the authorities, with the government, just to have the reimbursement of the holistic approach to atopic dermatitis patients. There is really a lack of this holistic approach in our country, and we learned from the literature, we learned also from the experience of our colleagues from the neighboring country. I'm just thinking especially about the Germany, and there are so many studies showing that the patients receiving just the same treatment modalities, but the patients who are under the holistic approach with the psychologist, with the dietitians and so on, they are treated much better, or they are coping with the disease much better. There is a burden to the sick individual, there's a burden to the family. So that's really just a huge problem. So we should work together with your colleagues, trying to have this let's say atopic school even better organized. There are just several atopy schools in different universities. We are not paid for it. There is no structure. Everybody is doing his own work according to his or her own ideas. It's very good because we are educating the people. However, it's not structured and not organized. So this is just our goal for the future, and just to change this. And of course, there are new treatment modalities coming to the market. That's perfect, because there was a lack for the effective treatment, especially for the more severe disease, but the basic work with the basic treatment, with the emollients, with even the topical steroids and calcineurin inhibitors, because we will not just avoid this, we will not escape from this, but that must be applied in a correct way. And you were talking about the phobia. We know that just a topical treatment with the steroids must be controlled by the doctors, but then we may have some adverse events, and that's also that should be taken into the consideration. Thank you very much.
Thank you very much. So this is the short summary in short view. And are there any questions? We have some minutes. So are there any questions? Oh, yes, please.
I'll try to talk loud. I'm Michelle, from Canada. My question was just about...
Maybe I will give you, Michelle, I will give you the microphone.
Thank you. My question, my name is Michelle. I'm from Canada. My question was about your multidisciplinary clinic, which sounds amazing. I was just wondering if you have all the specialists together at the same time for the patient appointment, or if it's coordinated over multiple visits.
Yeah, this is a very good question. Thank you. Yeah. You just predict and my future talk about this center, because now at this moment I was talking only about the multi-speciality approach to patient education. Yes, and of course we work together and we meet together in one place. However, answering your question about the specialists generally in the care of AD, not only in the education, of course our goal is to be in one place in the same moment and just have the patient with AD in the center. So we are working on it. Of course, it needs much more regulation, the authorities, agreements, and refundation, and so on. But I think we are on a good way. We have just started this process, but it's more general. I will share with you these ideas later. So thank you for this question. I know it's now a new trend for this multi-specialty approach. So, yeah. May I also ask for another microphone from our wonderful team, technical team?
Congratulations, Magda, and to the whole team, to your holistic approach in patient education. Peter Schmidt from Switzerland. One thing I would like to know, how you train the trainers. You have special courses for them, and we have a privilege by our foundation to make also a, let's say, a nurse-patient consultation eye by eye. Do you also use this tool? Because sometimes they dare to ask much more than if it's the doctor or the professor. But congratulations what you all do together.
Yeah. Thank you for this comment. As Professor Szepitowski told you, we do not have the special structures that we just multiple the same standard. So of course, we do not have only special dedicated nurses for atopic dermatitis. So we usually work with the nurses who are dedicated to our outpatient or department, who are used to deal with AD patient. And of course, this is another gap to be covered in our country, to just cooperate and have the special structures to teach the healthcare professional and nurses together. But of course, it needs a solution from also from our authorities, because it's not refunded and reimbursed, but it is a very good way to follow, just as it is in your country. So we will learn from you more. Okay, are there any more?
So thank you, Maga, for this very interesting topic. I would like to question you about the distribution of dermatologists in the country, because in other area, in our setting, dermatologists are mostly posted in big city. I don't know what's the situation in Poland.
You mean the distribution of dermatologists?
Yeah.
Yes, so this is a good question, and maybe I will share also this question with Professor Szepietowski, but we are, as I told you, over 2,500 dermatologists, and they are mainly gathered in the main cities, yes, but not all, yes,
Thank you for the question, but I may say it's not terribly bad. Yeah? It's quite good, I will say. Of course, we are aware of the problems with the distribution of dermatologists all around the world, and I'm working quite closely with the Ethiopian colleagues, and I know that the majority of them are grouped in the capital city. Yes, so that's completely different if you compare to the Polish standard. It's quite clear that the vast majority of dermatologists are grouped in the main cities, but now we have so many, you know, let's say university cities distributed through the whole Poland. So the access to the dermatologist is quite easy in my opinion. Also, the regional outpatients are located outside the cities, even in smaller places. So if someone would like really just to have the meeting with a dermatologist, the fixed appointment, that should not be a huge problem. Of course, there is a queue if you are just thinking about the reimbursement, but that's possible. So I personally do think that the distribution of dermatologists is quite good in Poland.
Thank you. I think that we ran out of our time. Yeah. So I would like to thank you, all my colleagues, for accepting the invitation and share with us and create some kind of round table. Okay, so thank you for the invitation, and I will just... Yeah, I will just ask Roberto to continue with this, and Professor Stalder to continue with this wonderful project.
Thank you very much. Dziękuję. So we're going to move on to the... thank you for all the Polish colleagues. It was really nice having you introducing this session. And so we're going to move on to another continent. We're going to go to Africa. And I'm going to like to invite Dr. Usman Faye from Mali. I don't see Nosa Dlova from South Africa is not here, so Usman is going to moderate this session. Thank you very much.
Good morning, everyone. So to introduce this session, I have the pleasure to give the first talk of this session about the clinical specificity in atopic dermatitis in Africa. So before I start this presentation, I would like to thank most sincerely the organizing committee and also International Society for Atopic Dermatitis, in particular Professor Alain Tayeb and Peter Schmidt for having me on board. So the clinical specificity of atopic dermatitis in Africa, this is a very interesting topic. As you may know, atopic dermatitis is an itchy chronic or chronic relapsing inflammatory skin condition that often start in early childhood, usually before the age of 2. And it is characterized by the onset of eczematous lesion that mainly involve the face, flexural area, and it's also frequently associated with atopy and dry skin. The disease The disease presentation is mostly influenced by the genetics, as you may know, and also environmental factor. So my today objective is to present the clinical specificity in Africa while highlighting the impact of the skin pigmentation. It can influence the appearance of dermatological lesion and also the social and cultural practices like the use of herbal medicine, the cataplasm, and the concept of chronic disease. So before I end my presentation, I will briefly present a previous paper we did on the validation of sclerad and post-sclerad on pigmented skin. So atopic dermatitis, usually in infants, start around the age of 2 or 3 months. Itching and rubbing is very common. Eczematous lesions are symmetrically distributed, involving the face with the respect of medial portion of, in particular, the nose and lower limbs. So this is an infant of 3 months here. As you can see the erythema on the cheeks and very slightly scale also. The front is tend to be spare. There is no erythema on the lower limb, as you can see. This is specific to African descent because of the pigmentation. Erythema is not obvious. This is another child with eruption of the cheeks with papular pattern, and also we have involvement of the lower leg and also the trunk. A complication of the use of, an adapted medication like steroid ointment, as we can see, and the left side and the middle, the same patients who moves from doctor to doctor and using an adapted treatments like herbal medicine. So the major part of the face is not spared because of the use of herbal medicine and sensitization. In the fold of retroerectal fold, we can also erythema and scalp lesion. Can be more severe in some kids, as you see in the left, excoriation on the cheeks and hypopigmentation because of inflammation. And the middle, we have crusted and ulceration lesion over the cheeks and also in the front. The major portion, in particular, as mentioned before by Alan Taeb, it's a spare. A super infection of another the site. So in children, other than severe dry skin is very common. Eczematous lesions tend to be more localized and they fold, involving bastion area. The lesion tend to spread. We have more flare can be seen on the trunk and also limb. Super infection is less common at this age, but lichenification predominates over erythema or edema. The subpalpebral fold are also prominent. So this is a patient, we can see scratching is obvious on the face and the trunk. So dryness at the left, this is a boy of 4 years with very dry skin over the trunk, limbs, and in the middle we have small scarlet lesion like each, and also in the lower limb. This may be misdiagnosed as a vulgar ichthyosis. So a more involvement of the face, erythema is not obvious, but in a fur skin it can be easily seen. The involvement of the neck is also common, as you can see in the middle, this child with grayish eruption over the neck, both sides. the same child with eczematic lesion of the antiflexural fossa. The same child with involvement of the wrist, it can be misdiagnosed as scabies. In the right side, we have involvement of a fold of knee with also erythema. It's not erythema, but it's grayish feature of the buttocks and thighs. A separate infected lesion with scratch and ulceration over the fold of the knee. We can also see some nummular lesion on the lower limb, and as mentioned before, the involvement of the neck with grayish, which could be presented as erythematous lesion with scare patient with fur skin. So the papular eruption is also common on black skin, as you may see in the middle, the papular eruption of the axillary fold. Also, nummular lesion is also seen. Superinfection is very common. Because of the use of an adapted treatment like herbal medicine or scratching, or also because of at this age, sometimes people do think that when we use soap to clean, it's tend to be exacerbated. So erythematous lesion starting mild eruption of these two children. We have more involvement of the trunk. We can see the micropapular eruption over the abdomen, and also a pigmentation and lichenification of antecubital fossae. So, as previously mentioned before, involvement of the neck, both-sided, and we can also see very small papule and pigmented area of the neck, which can be erythematous with fur skin patients. Lichenification tends to be more common in the child, in adolescent, as you can see, of the buttocks and also abdomen of the same patients. Separate infection and very dry skin is also seen in adolescents. You can see a crusted ulcerated lesion. Dry skin is very common at the age above 5 and 10. We can also see hyperkeratotic and hyperlinearity of the sole and palm. Denim organ fall is also common in early age, as previously mentioned by Alan Type on a previous paper. We can do a spinoluzic a pattern in the middle, and a pigmentation and lichenification starting at this age. So in adult, because of the use of herbal medicine and adaptive treatment, the lesion tend to be spread and cover over other part of the body, and it can also misdiagnose because of if you don't have a history of the patients. It could be diagnosed as a simple eczema. You have to ask for a medical history of the patients. So this is more lichenification in these patients and teenager, and also a more lichenification, thanks to Professor Ball and Professor Augo for giving me these images. So in later in adult, the eruption can change, and it could resemble to psoriasis like this patient all are atopic dermatitis at the age of 40 or 50. So before I end this presentation, I would like to present our previous paper performed in a multi-center way in the West Africa, covering about 7 countries in West Africa, from Gabon to Senegal, in which study we took part. So we tried to validate the SCORAD and PEU-SCORAD as published by Professor Staller before. With visual aids, the SCORAD and PEU-SCORAD has been evaluated by both patients, parents, or dermatologists in the West African country. The result was most of the cases seen in this setting were mild or moderate disease, and their assessment, we accurately assessed symptoms like the severity of the disease or oozing or crust, but there was an underestimation of edema or erythema simply because of the pigmentation of the skin. On the other hand, has been overestimated with scratching, lesion, and lichenification. There is a good correlation between the physicians and the PEU-SCORAD evaluated by the physician and the parents. So in conclusion, the specificity of atopic dermatitis in Africa are as follows. We have the issue of evaluation of erythema and edema, as well in particular in dark skin patients. There is also a possible frequency of complication due to power agent and the use of unadapted materials. The high frequency of lichenification and papular presentation of the neck is commonly seen. We have also a risk of misdiagnosing the disease in adults. Most of patients are presented with mild or moderate disease, and there is a need of investigation of microbiota and also the assessment of erythema in a pigmented skin. So thank you for your attention. So the discussion will come later. For the next presentation, I will invite friends from Madagascar, Rapelonoro Rabenja, for giving a talk about the organization of care of atopic dermatitis in Madagascar. Rabenja is a professor of dermatology at the main city of Mada, right? Thank you. You have the floor.
Thank you. Thank you. First of all, I'd like to thank here the organization committee to invite me to talk about how you organize therapeutic education in Madagascar, and maybe it's the same in Africa. And thanks for the board of ISAD to invite me. Take care of atopic dermatitis is a big challenge for us. I hear it from her. And it's more difficult for people who work in a limited resource. And I'd like to, where is the, to divide this talk in 3 parts. First of all, I talk about the journey of the patient with atopic dermatitis and how we do in our department and how we take care of the flare-ups. My colleague showed that there are many cases seen later in Africa, and for Madagascar, it's the same, but only for phototypes 4, more, and 5. We agree that the big problem in the management of atopic dermatitis is to take care of priorities because it has a high impact in quality of life. And Madagascar is a country bigger than France and Benelux, but we are only 15 dermatologists, 8 residents, and we have 30 medical doctors, general practitioners who work in the field who aid us in dermatology. The prevalence of atopic dermatitis grows every year. In children, it's about 1% in 1999, but 20 years after, it's grown to 5.6 with a study for all over the country because we go to the field 3 times a year. The atopic dermatitis is seen before by caregivers, and after they could be done by general practitioners who use many medicines before, and after by pediatricians for children, and at least by dermatologists, we are few. And in the healthcare primaire, in the field, many cases were seen by caregivers before they go to the reference center. Caregivers are faced by itching, a big problem of itching and dry skin in our country. And they think at first it is a heat rash, food reactions, fungal infection, before they think that it might be an inflammatory disease. And for the patients, before they go to the center, they go to the healer, like in Africa, and they use many things, and they think that it's a problem with diet, environmental factor, and I don't know in another country, because in my country, when patients have a rash, they think that it's a liver disease. I don't know why. The journey of the patients, at the beginning, they are seen by traditional healer who use many medicines, you don't know what. And in general, patients can control the flare-up, but they go to the dermatologist only when there are an infection and flare-up, like the photo presented by Osman Faye. And many of them were lost. And we organized in our department during 1 year. The first consultation, the patient are seen by a resident, and the resident developed a medical files using score in atopic dermatitis. Thank you, Osman. And they educate patients. They stay with the patient for more than around 30 minutes, how to introduce topical treatment, emollient or topical steroid in case of inflammations, and to reassure them when the patient have a long period of flare-ups. You know that it's very difficult to explain to the patient and the family. They need to be treated for a long time if they want to have a quality of life. And we think that therapeutic education is the best treatment if we have a nice follow-up, and we show that we can have an improvement using only best use of emollient, moisturizing, and corticosteroid first-line treatment with the best follow-up. Our big problem is a high percent drop-top. At the beginning in 1999, we have 30% patient drop-top after 2-month follow-up, and it decreased to 64 in 15 years ago. And it supports that we need a strengthened therapeutic education, but therapeutic education need it's consume times and you are not enough. And we want to explain to the patient what is a friend of atopic dermatitis and what they need to forbidden. And we explain soap, there are many soap in the market, but we explain that they need to stay less than 5 minutes in the bath. Patients think that showering too long is best for them, but it's an error. And we explain too, applying cream to seal the wall is needed. And we have many cream in the market. It's a traditional market, and many of them use cocoa oil, but it is not good for dry skin. And we explain that applying cream is needed to seal the hole, and at what time, with which dosage, and in which region. And it's the same for the use of corticosteroid cream. And we gave them flyers who show the thing that the skin of people with atopic dermatitis cannot tolerate. And our study, it's in the poster 63. We saw that the comorbidity seen in our department is smoking, nasal polyposis, and food allergy. And we have a high correlation of comorbidity with occurrence of AJ in passive smoking, and correlation of comorbidity with AG flare-up in personal atopy. We have received a fund from Dermalink to education therapeutic and to help patients to better manage their condition and improve their quality of life. And we organize individual interview to explain what is AD, triggering factor, aggravating factor, prevention, and we are on time to explain in the app how they want to do. And we think that it's very important to teach patient and family in a group because they can share their experience each other. And we organize every month patient education with their family. And if you organize for 20 persons, always we have the double because it's become a big event for the family with atopic dermatitis. And it is an occasion for us to evaluate our residents too. And we have a nurse who take care of this. And many cases at the beginning were seen by nurse. And we think that even we need another therapeutic in case of chronic disease. We think that the basic treatment, emollient and corticosteroid, using with a follow-up every month, is a gold standard for the treatment in our country. Thank you for your attention.
So thank you, Professor Rabenja. You can go and sit. We'll discuss after. I think the next speaker will be online. She is from Kenya. Oh, she's from Kenya. Rachel Ogola will be giving a presentation about the therapeutic consent for patients. Can you hear us, Rachel? Okay. So
Yes,
you have
I
the
can
floor.
hear you. Thank you very much. I'm glad to be joining online. So my topic is therapeutic constraints for patients with eczema, with atopic eczema. I'll start with affordability and poverty. Like we know, creams are very expensive. Of course, even affordability is a problem. Most of the creams are imported creams. We don't have them locally, especially here in Kenya. We have to import most of our creams. And then treatment also, to be able to see an expert is also an issue. You have to put in money to see an expert. And by the time you get to see the expert, you have seen a number of probably primary care doctors, first-line doctors, the general, the GP, probably 3 of them before you are diagnosed with eczema. So the affordability is a problem, and of course, we are a low-income country, so you can imagine out-of-pocket costs. And then even insurances don't cover most of the creams and emollients that are used for the treatment of eczema. You have to use your own money to do this, and this has really burdened patients. Again, our medical structures, our accessibility to our medical structures is also a problem. We have only 30 registered dermatologists against 55 million, a population of 55 million people. Most of the dermatologists, there are 30 registered of them. So most of them are within the city. You can imagine outside of the city how it looks like, you know? So it's a big problem. Then, of course, the governments have really ignored the area of skin. They actually say emphasis is on tropical diseases. That is where the funding is. I don't understand why funding is not on the area in the area of skin. I think people in this area, stakeholders need to make more, probably escalate the issue. You know, the reason why, there is no reason why in 2023 we are still talking about the area of skin being ignored. We don't have research centers, and if we have research centers, they are underfunded, no experts, you know. So that is an issue that needs to be looked at even at this conference. Then, of course, there's lack of treatment guidelines for eczema in Africa. You know, I'm afraid to say that in this century, we are still using treatment guidelines from Europe and Asia. You know, I don't understand why we still don't have our own treatment guidelines that speak you know, like that relates to us, you know. And then, of course, there's stigma on treatment. There's the fear of, you know, there's that belief that eczema treatment is taxing, is complex, and also there's concern about the safety of most of the treatments. And then at that point, I also mentioned the fear of steroids. I particularly have suffered that with my children, because at the time when my son was 6 months old, and then there was a prescription that we took to the pharmacy, and the pharmacist said, no, this prescription, the amount of steroid in it is too much for a 6-month-old baby. So we just don't know what steroids are doing to us, what they will do to us. We need to understand, what do these steroids do? Can we have medication that do not have steroid, or something better? Okay, and then there's lack of clinical trials in Africa. Most trials are done abroad. Most trials I see are done in African American skin. We don't have Black African done in Africa for Africa by Africa. So that one throwing that challenge, of course, to pharmaceutical companies. I think they need to look into this, and that's why most of the treatment we have does not really work on our skin, because it is not for our skin, you know? Then there's poor patient adherence, of course, due to poor support and management, and of course, ignorance comes in here also, and illiteracy. You know, most of the treatments are, like I mentioned earlier, they're probably complex. Also, they require strict adherence. Most of us, we want to run to work to get our daily bread. We are a low-income earner, a low-income economy. So all that is also because of poverty comes in, and ignorance. Then development on modern technology. We are still, our technology is still not developed. So we lose out on emerging technology, emerging medication, you know, and then of course cultural beliefs, illiteracy, as I mentioned. We believe in many things. We believe in witchcraft. We believe in other things that do not really help us, and that's how we are really constrained. And then there's lack of resources and training tools. We need more resources and training tools for atopic eczema. There's very little information. And then, of course, poor infrastructure, lack of clean water and safe water, air pollution that probably even aggravates the situation further, you know. I'm just running with this. So some of the takeaways, I don't know my screen. 1 second. Oh God, my screen is kind of failing me. The takeaways. Are you able to take me to the takeaways? Yeah, okay. The first slide, okay, yeah, the first one. Sorry about this.
Okay, your screen disappeared for a while, but it's back.
Yeah,
okay.
So I'm just saying the takeaways. The government should endeavor to achieve universal health coverage and access to quality health care for patients and caregivers. Of course, that includes improving our hospitals, access to medication, improving, training more doctors, more experts in the area of skin. Also, address affordability of medication. You know, our medication is very expensive. Most of it is imported. So by the time it gets here, it's been levied with very high tax duty and imports duty. We can hardly afford them. Then intensify continuous professional education for skin experts, especially on new drugs and emerging technology on atopic eczema. This one, I know the doctors in the house will agree with me. We need more tools and resources, and of course information on eczema. We need to lobby for research centers, and more research should be done for atopic eczema. There's very little research on atopic eczema. I don't even know whether we know the number. I'm glad that Global Skin is doing a research on numbers, and I hope most of us have heard about it. We need to know what numbers we are. Also, we need to develop, the government should, and policymakers, to develop treatment guidelines in Africa, you know, so we are able to get what relates to us. Policymakers to also help develop policies that improve the treatment of atopic eczema. And by the way, I'm still here lobbying for eczema to be classified as a chronic condition. In Kenya, it is more expensive to treat eczema, atopic eczema, than it is to treat diabetes. Yet diabetes is has been labeled as a chronic condition. Treatment has been levied off tax, and also the the tools, the gadgets used for diabetes are not taxed, so it is easier to manage diabetes. Yet, eczema is more expensive to treat, but it has totally been ignored. It has not even been labeled as a chronic condition, not even been considered yet, because probably we are not making much noise, you know. Then I want to also throw it to pharmaceutical companies, more trials on drugs, also consider manufacturing drugs in Africa locally, so we're able to afford, you know, increase more funding to governments, support patients, and organizations and associations that carry out the work of eczema advocacy. Yeah, I think that's enough. I'm done. Thank you. I hope I kept time.
Thank you so much, Rachel. Your voice, we hear your voice. Okay, so we have time for a discussion.
I have a question because you spoke about something called cataplasm. Yeah. So I guess this is a problem of cultural, some cultural beliefs, and I think we have the same thing in Brazil, which patients, they go through many treatments, many doctors. Some of them just decide, I'm going to do something else and go to spiritual healers. And is this a big problem for you?
Yes, it is, because we perform a study in our setting about the treatment taken by a patient before reaching our center. Almost 3% to 40% of patients we came to us for chronic skin condition has already been seen by traditional healers or ever have take herbal medicine. And sometimes they also use drug out of the counter, or mainly in rural area, it's very common to see patients using, herbal mixture of herbal medicine or something. Many things are known, but they put on lesion, a crusted lesion, or ulcerated lesion, so that to get killed. It's quite common in our setting.
So just the last question about that I would like to know is, we've seen an increase in I guess, in atopic dermatitis in Africa. I would like to maybe have your impression if it's connected to different lifestyles, more pollution, or people moving to the urban centers, because we always had this idea of atopic dermatitis being related to industrialized nations. And so I'm just always wondering about what happened that the rates of atopic dermatitis are increasing so fast in Africa.
So I don't have the answer, but what is known today, atopic dermatitis, the frequency of atopic dermatitis is increasing. In our setting, we have a release of statistics yearly, and as compared to previous report, I found it that the hospital prevalence of atopic dermatitis has increased. It was less than 0.5% 10 years back, but the last release of the statistics of our department revealed that the prevalence is in our hospital is 3.5. The causes, I don't know, but we are in a very urban area, and urbanization is increasing. As in many African capital cities, there is a very huge, urbanization, and also pollution, environmental factor like the multiplication of ointment, the multiplication of the access of cream from abroad, from anywhere. I don't know exactly the causes of this increase, but what is known today is we are facing, obviously, an increase in the prevalence of atopic dermatitis. That we need to explore, to investigate, mainly the cause of this increase. Yeah.
I agree with Usman, but I think that we can have two applications. First one is during the beginning of this century, we have more dermatologists who come back to the country in Africa, and we have high level of expertise in dermatology. As I show you, at the beginning in 1999 in my country, the prevalence hospital is 1% in children, and we go to the field during our field mission, because we have 3 field missions for neglected tropical disease, including all of the neglected tropical disease, such as chromoblastomycosis and sporadic, and we add atopic dermatitis, and we publish I show it this afternoon. The climate have a big influence in this flare-up, and it's the same in the field if you compare to the hospital data.
Okay. So any question? So I have a question for you, Rachel. So I'm strongly interested in the access of dermatological care. So I'm wondering what is the distribution of dermatologists in Kenya? How many are you in Kenya?
Richard is not.
I'm not a medical doctor.
Yeah.
Yeah, but there are about 30 registered dermatologists.
How many?
30.
Okay.
30,
Mm-hmm.
30, yeah. And our population is 55 million.
Wow.
Yes.
Okay.
And of course, 80% of them are in the city.
Yeah, okay, of course. Okay,
Yeah.
so thank you.
So you can imagine.
Yeah. The audience? Yes,
I have a
Professor
question.
Tayeb?
Yes. I'm happy to see that there is the voice of patient from Africa with Mrs. Rachel Ogola from the Eczema Society of Kenya. She contacted our society a few months ago because the Eczema Society of Kenya was applying for a grant for ILDS. I remember for the Sudanese refugees in Kenya. And according to the grant, it seems that also in these camps, there are a lot of cases of atopic dermatitis. So I have 2 questions to Mrs. Ogola, if she is online. So any idea of why is it maybe more prevalent in these refugee camps? Or is it also a mixture with other cases like scabies? And second question, because I'm not sure that there are so many patient advocacies in sub-Saharan Africa, except maybe South Africa. So do you have any network of patient advocacies in sub-Saharan Africa?
Rachel, are you online?
Yes, I am online.
Okay,
Thank you
right.
for the question. Thank you for the question. Yes, I would like to respond. Actually, about the grant, we did not get the grant. So we are still lobbying for it. We hope to get from another. ILDS did not give us the grant. So we hope to try again, or we are trying to lobby to see whether another organization can give us the grant. So I don't know why there is high prevalence in refugee camps, but obviously, again, because at the camps, nobody looks at your skin. I mean, skin conditions are totally ignored. Of course, again, emphasis is on tropical diseases that are funded at that point, probably to the malaria, you know, and others. But skin diseases are actually, when we did our survey, they don't even go to the to seek medication because there's nowhere to go to. You understand? So probably also because other skin diseases like scabies and of course all these others like psoriasis and the eczema, all of them are all, you know, they all go together. So nobody really has taken time to even classify which is which, because there is no attention on skin diseases completely, unfortunately. Yeah, so probably that's why there's a lot of prevalence, because, you know, because of that. And then again, and probably also because of the conditions they live in, you know, the environment as well, you know. Of course, there's the hygiene issues, sanitation issues, concerns there. And then patient organizations in Sub-Saharan Africa, they are also there. I know in South Africa there are more, but they're there in Sub-Saharan Africa. It's just because they are probably underfunded, so they don't get the arena to echo their voice, to amplify their voices. They don't have resources, but they're there, and I have access to some of them. Are quiet or probably not being heard because of course, lack of resources, finances, and even support in terms of tools, you know, toolkits, and it's all about funding. It's all about also, like you're saying, not getting the platform. Because, like you're saying again, the area of skin has totally been ignored. I feel like dermatologists also need to talk more about the issues affecting Africa, you know, in a louder way, in a more aggressive manner. Thank you.
Okay. So thank you, Rachel. Any other question from the audience? Yeah.
Yes. Good morning.
Professor Bal?
Sorry. Oh, dear.
Oh, sorry. Sorry. Oh,
yes.
Yeah. Erere.
Yes, please.
Yeah, before. Yeah.
Yes.
Yeah.
Thank you very
sorry,
much.
Yeah.
Okay. Thank you for all the presenters, and I have two questions for Professor Faye and Professor. I can't remember his name. Yes. So, in your study for Madagascar, you had mentioned food allergy and allergic rhinitis, and also personal history of atopy as prevalent factors. I think I saw that on the chart. And I just wanted to know if you considered family history of AD as well, or atopy, not necessarily atopic dermatitis. And if the food allergy was, I mean, how the diagnosis was made, because if I recall, it's like you ask the patients as opposed to maybe, and obviously what you saw, because we find that a lot of patients attribute their flares or something to a particular food. And for pediatrics, I mean, I'm an adult physician, I have to see pediatric dermatologists because we don't have too many of them in the country. The parents or the caregivers want to avoid all meals in their idea that there's food allergy. So I'm just wondering if there was a particular, I mean, what was done, if you could just expatiate on that, to really see, you know, be sure that food allergy was that, and not just that parents or caregivers were taking food away. So that's one question for you. And of course, the family history of atopy, which will give us some information and not just the personal. Then for Professor Faye, you were mentioning, I saw the pictures, and I was wondering, when we see severe eczema, when we actually see those patients, and we, the dermatologists, we who know, say, oh, this is impetiginized or bacterial superinfection of an eczematous condition, as opposed to who had seen them before. how are we able to really differentiate? As we can tell, but they can't. And if your study was on what they came to tell us, I don't know if I'm just trying to understand how we can explain to the patients that this is not eczema, this is bacterial super infection for whatever thing, because they will scratch normally and we can have super infection. But we actually have, especially in Africa, many patients who look like they're having an eczematous reaction. And it's just some other thing that they have maybe used, like irritant contact dermatitis. They've used herbal and rubbed all over for something that was simplified. So if they don't come to us, and I think it segues into what's in Madagascar, who has seen these patients before they come to us? What have they done before they come to us? And then they have what looks like a very severe flare. And meanwhile, we're dealing with something else completely. So in asking patients or caregivers to make a diagnosis, it might be difficult because they don't know all the things that we do. So I think we still have a lot of work to do if we're trying to get the primary healthcare physicians to do the right thing before coming to us. Because I would say first do nothing at all. But chances are it will take a long time for them to come to see us. So they can't not do anything. They will do something. So how do we marry and help that situation? I don't know which of you will answer it, but I know I face it and I suspect you face it as well. Then for Rachel, very good, thank you. I know we met in Singapore and she's very particular about patients' care. I think the question is not for other people to sort out, it's for us in Africa to sort out. When we talk in terms of whether these studies to be done, where are the studies, what should be done for Africans living in Africa with African environment and African situations, so that even if we're talking imported medication, imported drugs, imported moisturizers, we can test them within our own locale and see, are they saying exactly what they claim to be saying? And it was very, very, very important. I thank you for bringing to bear that DM is chronic. And DM is probably cheaper to manage because they've given them a lot, diabetes mellitus, I'm sorry for shortening, giving them less, it costs less to manage DM than AD. In my country, the health insurance, even for private, it's not just national health insurance scheme, they will just say no for emollients. This is considered cosmetic and it's not used. Meanwhile, the patients are suffering. And if you tell them, okay, go get this locally, chances are those local products have been mixed and matched with so many things that will cause some more contact dermatitis. So we are back to square one. So it is a problem, and I do think it's something that we definitely need to talk about more. Thank you very much.
Thank you very much, Erere. I will start responding with your question. The first question about the severe type of AD. Patient with super infection, severe type, what they did before coming to us, what do they use? It's not easy, but so what we're trying to teach and also to get primary care worker aware is when facing a patient with a severe type of or super infected atopic dermatitis, the first thing to do is to treat the super infection and then to look after what is the probable cause of the skin condition. But it's not easy when patients use herbal medicine because of sensitization. The spread of the lesion is not easy, but that's the first treatment is just to remove the super infection and to see afterwards what's going on this patient. So regarding the second question about the use of emollient, as yesterday in our meeting, I addressed the situation in my country. We used to have one of the emollient covered by the national insurance system. It was prescribed, it was reimbursed by the national insurance system. The prescription was going on, and there was a large prescription of this emollient not only by dermatology, but many GP. At what extent the national insurance system remove it from the drug covered by this insurance. So they also remove all of the, local preparation with paraffin or Vaseline, with urea. They also remove all this medication from the list. So we try to come back again and to tell them it's very important. It's not, cosmetic. It's very important for us. That's the only thing we have for atopic dermatitis. But the battle is still going on. We are, sure to come out, but it's not easy. So for this national insurance to balance what you really need, or to have a kind of restriction in the prescription, so that patient can benefit it. That it's a battle going on.
Okay, we're gonna.
Yes, thank you, Usman. Thank you, Benja. Thank you, Ms. Ogola, for this nice presentation. I have just 2 questions. The first one about this concept of chronic disease in Africa. How do you explain it? Because it's very important. This concept is explain the fact that people don't accept their disease. They are trying to go from one medical doctor to another. They go back to traditional medicine. Is it related to the knowledge, to the development, or any other factor? Second question for Mrs. Ogola. She's advocating for African guidelines. I want to know what are the reasons she's advocating, because the differences are only on the phototype, the skin, and also the availability of drugs. I don't see another reason why we need specific guidelines for Africa. Thank you.
Okay, so thank you so much. I would like to say it's a matter of education, but not only, because even in well-educated population, they use herbal medicine, they keep going to see a traditional healer. It's a matter, not only a matter of education, but a matter of social practices in our setting. Yeah.
So just a question concerning your feeling about the role, future role of not only on specific guideline on atopic dermatitis in Africa. I don't know. That is it's a first discussion. But the second one is, do you think that the new electronic tools are usable in the next future in Africa? And I would like to ask especially our colleague from Kenya, Rachel Ogola. Do you feel that the people with their phone are able to connect themselves and to receive help from maybe from website or other things?
So Rachel, are you online? Are you still online?
Yes, I am. Yes, I am.
Okay, did you get the point?
Yes, I did.
Okay,
the
right.
last one I didn't get quite well. The one for the phones and the website, I didn't get it quite well.
Yes, we're talking about the digital tools for atopic dermatitis. Is any way to be connected to other people? So yeah, and it is usable.
Okay. Okay. So thank you very much. So the question on African guidelines, yeah, it's I feel like it is important to have our own guidelines that relate to us and that makes more sense to us, honestly. Of course, it's about, you talk about availability of drugs, but again, we can't be why not have guidelines that have, you know, like are more relatable to us by, you know, to our patients, to our doctors, to our skin, you know, medication that works for us, treatment regimens that make more sense for us, work for us, you know, because most of these things probably don't even make sense to us. They don't work for us. They don't really relate with us, and that's why you see patients, like I mentioned in my abstract, patients complain that eczema treatment is complex. It is complex for them here. Probably it is not complex in Europe or Asia, you know, because they feel that it's not probably well explained to them, or it is not making sense for them, you know. So it all narrows down to our level of development and advancement. And then the other question was about the digital tools. Yes. If we had, of course, the digital tools, I know there's access, even if accessibility to phones is limited, there would be one or two people in a setup of a community, or you will set up digital centers where patients can always check in. I know there's someone who was doing a very good project in Madagascar. I don't know whether it is one of the doctors in the house on digital tools, and it's just an arrangement where probably in a community where people do not have phones completely, or even internet or access to technology, but there will be a center where one or two people have the phones, and probably they're using solar or something. So the others would access, the rest of the community would access resources from that particular center, you know. So like that, with that, it makes sense, you know. Yeah, so if they got this kind of resources, it will make a lot of sense for them. The idea of phones and probably the idea of websites, there would be one or two people with a laptop in the setup. They're normally called navigators. So the navigator is at a center where the rest of the community are able to walk there and get whatever resource it is that they have to. And even the navigator has information as training on atopic eczema, management, and drug use, you know, yeah.
Okay.
So,
Thank you very much, Rachel. Wonderful. The fact that we can talk this on, can do this online is fascinating. Thank you for this fascinating session, and we're going to reconvene within, I think, 15 minutes. 10:15, please. We're going to have a break now, and we'll continue at 10:15. Thank you very much. Thank you, Usman. Thank you.
Peter Leo. I'm a clinical assistant professor of dermatology and pediatrics at Northwestern University, Feinberg School of Medicine in Chicago.
We have to introduce, I'm going to moderate, so do you want, should I just, yeah. I think I'll just talk and now Okay, we're going to start the second part of this session. I'm going to moderate this next session. So we're going to talk, to address therapeutic failure in atopic dermatitis. You probably know that despite all the new medications and all the things that we're doing for the patient, we still face therapeutic failure. So we have the pleasure of having Professor Stalder and Fanny Santenac. They're going to present their views on therapeutic failure from patient's point of view and from the medical professional point of view. So thank you very much, Jean-François.
Thank you, Roberto. Please. So I think it's, for the first time, we will present our experience in a dual approach, mixing patient voice and doctor voice. So I think it's the first time. And we try to do that from the conception we did and also to the talk. So let me introduce Fanny Santenac. Fanny Santenac is an expert patient living in Toulouse, in France. She is trained in therapeutic patient education. And she suffered from severe AD since birth. And she is a creator for social media, dansmapeaueczema.com.
Well, my turn to introduce Professor Stadler, should I? Because most of you know him. He's an emeritus professor of dermatology from Nantes in France. And he created one of the first schools of atopy in France. So I'm very glad to be there with you and to represent one of the patient voices.
Thank you, Fanny. So I think we have some slide dedicated for patient point of view or dedicated for healthcare provider point of view. At the beginning, about what the definition of failure to treat, I think the definition depends on what is expected. So at the short-term level, we observe a patient and doctor convergence because we would all decrease the symptom, improve the quality of life, initiate a significant remission. But at the long-term level, it's a little bit different. And the patient and the doctor has sometimes divergence. And because patients would like to find a complete and definitive cure. And for the doctor, I think they would like especially to keep the disease under control. So finally, the insufficient response to logical intervention and the absence of change in condition despite efficient medication correspond of definition of failure to treat. Do you agree?
I do. And from my patient point of view, there are really mindsets that you as doctor has to address when you meet a patient. First, ask the patient understand that he has or she has a condition. Not just a rash, not just an allergy or a food allergy, not just a dryness. That's a real chronic condition. So first of all, does the patient understand that? Second, does the patient understand that this condition is chronic? And by chronic, it doesn't mean that he has or she has to suffer all her life or his life. Of course not. It just means that they have to manage their skin on a long term. And most of the time, they don't get that. That's why they wait for the miraculous cure. Third mindset for me is also, do they understand how the condition works? Do they understand that their skin doesn't play their role? And do they understand the difference between the symptoms? Do they identify the triggers in their life? Do they know how to prevent flares? And the understanding of the condition is a key point for them to accept the condition and to adhere to the doctor proposition. And the fourth mindset for me is accept their own part, their own role in healing. Most of the time, the patients have a passive posture and they wait for the doctor to save them. And what I understood from my history is that for sure the doctor is a helper, but we have also to manage our own role in our healing. On a long-term management, of course. So for me, those mindsets are key points that you need to address with your patients.
So, do you think about the patient expectation compared with the doctor expectation? So, from the patient expectation, what we heard during our consultation, coming from the patients, they want to obtain a complete and definitive cure by a simple action on short-term eczema. That is
short-term medication.
Medication. They also would like to find the root cause.
Wait, I just answer.
Oh yes, please.
Of course, we wait for a complete and definitive cure, but what we hear from the doctor is that it's a chronic condition that needs long-term management. We just said it. And there needs to be a partnership between the patient and the doctor to get the disease under control. And as we said, the patient have their active role to play.
Second point, important for the patient, is how to find the root cause and get rid of it. That is a really important point.
As an expert patient, talking with a lot of patients, I also hear that all the time. I don't go to doctors because they don't try to find the root condition that I can get rid of and get better. Of course, there is not a root condition. There are multiple causes that are genetics, and the patient has to make the difference between what they call causes and what we, more educated patient or doctors, call triggers or aggravating factors. That's a really big difference.
And for the patients, the medication have to be simple of use and also mainly without any side effect. So that is challenging.
Of course, that's difficult because there is no medication without any side effect. That's what the patient needs to understand also. So the doctors need to address the fear of side effects and not just ignore it. Of course, that's a real fear, and in AD, it's really one of the main problems. They have to help the patient identify the risks and the benefits from medication. At one point, when your condition is so bad that you cannot live your life, maybe medication and even side effects are a really small risk to take. So, and the doctors and their team need to explain better the exact use of cream and treatment, and cream especially.
And finally, to find a perfect treatment, bio-treatment, because I think it's in the mood now to obtain to use a natural product is expressed by patients. And
of course, we are all as humans concerned about what we eat, what we put on our skin, how we live, and we want to find natural alternatives. But the reality of AD is that often natural or bio products are not completely inoffensive. We saw that with the Madagascar team or African team, herbal medicine, or sometimes they can really make the flare worse. So it all depends. Of course, you can use natural product, but it all depends on how, why, and when you use it. And patient needs to understand that there are not alternatives for medication, there are complementary.
So that is a point of view coming from doctors. What are the causes of therapeutic failure? The first cause, the majority of the cause are due to poor treatment adherence, because coming from the patients and for many, many reasons. The second point is also sometimes we are confronted with intrinsic severe form of atopic dermatitis, with a score at more than 80%, and finally it's difficult to treat with only topical treatment. We also can be concerned by the comorbidities, and sometimes asthma or food allergy are also a problem we have to take it part. And the wrong diagnosis, is it easy to make a diagnosis of atopic dermatitis? On the white skin, yes, but I'm not sure it is so easy on the black skin.
We saw that this morning, yeah.
We saw that this morning.
From a patient point of view, or at least my expert patient point of view, the lack of adherence to the treatments have multiple origins. First, patients don't adhere because they don't understand the condition, and they have a big lack of explanation around the treatment. So of course they will not adhere because they don't have those information. That's why TPA is so important. And they have a poor exchange and a lack of trust with the doctors. And also, as we said, they need to own their own part in the healing. And often they don't trust the doctors because doctors minimize their pain and the impact of the condition in their everyday life. What we patients call severe, it's not the same as you call severe. And sometimes a very light and moderate form of eczema can really have a big, big impact in someone's life. So yeah, we have to take that in consideration when treating.
Sure.
It's also very difficult to find a common ground to discuss between the patient and the doctor because we don't have the same vocabulary, we don't have the same experience, we don't have the same history. So we come with we have like 10 or 15 minutes, as we saw this morning, and we meet with our history, with our vocabulary, and we try to find a common ground, and it's really difficult. And when we are talking about families and child, the parents is another part of the ground we need to find, and that's really difficult.
So, concerning the related obstacle for the HCP, the availability of the doctor is not so big.
No,
and not only in Poland, but also
everywhere.
Everywhere. Time is missing. The poor listening, poor investigation in patient experience, history and preference are also sometimes an obstacle for patients. The prescription is sometimes too complicated and without reference with the patient beliefs. When the doctor prescribes a treatment, but without asking the patient's feeling about this treatment, I am thinking about corticosteroid, I think it's impossible to imagine the the efficacy of the real applied treatment on the skin. And finally, we have a poor local treatment explanation, and I would like to highlight the role of a demonstration. We are lucky in our department, we have some nurses dedicated to do that, and I think it's very, very useful because the patient follow after the doctor consultation, they are going to the nurse consultation, and sometimes they know and they express a lot of things they didn't say to the doctor.
I just have to say that just one dermatologist changed my life, but he was not alone. He was with a multidisciplinary team, and the nurses really played a huge part by demonstrating the treatment. So for the patient, the obstacles can be the fear of treatment, the need to be reassured, the skincare refusal, so you have to address, of course, those kind of problems. There is a lack of trust, as we said, and they're also simply exhausted by the treatment, exhausted because it's too long, it's too complicated, it's too demanding, and they're also exhausted by the condition itself. They don't sleep, they itch all the time, and they have a lack of energy, and they are in despair of going better. And of course, they are in a lack of hope too. They don't believe anymore that the condition can be improved. My doctor gave me hope. It was the first in 35 years that I met that gave me hope.
So how to maximize patient adherence? I think we can imagine two different approaches. The human approach, the posture is a key point because empathy, listening is very important. And I think a lot of difficulties begin at this level. The systematic corticosteroid phobia is also a second phenomenon, but we need to detect that because it's very important. The patient education is not only information, but also include demonstration, follow-up planified during the first contact, and this contact can be done by nurses or the HCP team. So the second point is to highlight this pharmacologic approach, explaining the simplification and the medication regimen, considering the patient preference, that is a really, really important point, and to offer a more individualized therapy.
In the patient point of view, education is more important than information, because information, we have it. We have internet now, and we can get any kind of information, good or worse, good or bad. Leaflet, brochure, and documents are important, but they don't represent what an education process. Education material must be adapted to the ability and the expectation of the patients or their family. And as we said, demonstration worth 1,000 words. When you show how to use topical steroids cream and emollient creams and any kind of treatment, it makes a huge difference. And that's why teamwork is key, because if the doctor don't have the time, maybe nurse can find it, and it's a teamwork. And also, please, doctors, let the patient express themselves. I know you don't have time, but try, because you will better answer their question, meet their needs, and you can get to co-build the therapy with them. And suddenly you will find a better adherence, because they trust you.
So at the end, in conclusion, let me present 7 rules. Plan the long-term management, locate the poor adherent patients, explore the reason for their reluctance to local treatment, especially corticophobia or loss of confidence, accept the patient preference, simplify the local treatment, explain the therapeutic contract, and define a better patient-doctor relationship. So finally, could you please give us the final message?
Yeah, my final message would be that I am a very good example that it can change. I've gone through 35 years of deception and bad doctor appointments until I meet one team, one doctor that really changed my life with therapeutic education. So I'm a very good example that it is possible to create a dialogue and a good partnership between doctor and patients. And that's why I'm here today and committed to help other patients. So don't lose hope. And even if we miss time and a lot of stuff, we can do it.
Thank you.
Thank you very much for this fascinating presentation about this partnership that is so important in dealing with atopic dermatitis. So I'm going to introduce the next speaker, which is Leonardo Farias. Leonardo Farias he's from our university in Sao Paulo, Brazil, and he's going to talk about his own experience and about the case of the recalcitrant teenager.
Good morning. My name is Leonardo, and I'm a senior resident dermatologist at the University of São Paulo. First, I would like to thank ISAD for the invitation, and especially Dr. Takaoka and Professor Stalder. The title of my presentation is The Case of the Recalcitrant Teenager. To begin, I would like to focus on the meaning of the word recalcitrant. As healthcare professionals, when we heard the word recalcitrant, we almost automatically think in a severe case, for example, severe AD. But the concept of the recalcitrant is more than that. It's a case difficult to manage or operate, not responsive to treatment. And if you think in this word in the context of atopic dermatitis, we know that only few cases are considered severe, something between 5 to 10%. And when you compare this to the percentage of cases of non-adherent patients, something between 30 to 40%, we see that there are many reasons why the AD must be not responsive to treatment or difficult to manage or operate, and they are actually more frequent than the severity of AD itself. So it's this part that I will be focused today. And for that, I divided my presentation in 3 parts, and each one has a message that I will resume in the end. And for the first one, I will start with a story. That's my story. I am a son of a dermatologist mother and a physical education teacher father. And when I was about 6 months old, I started with some pruritic lesions in my skin. At first, my mom is a dermatologist. She thought I had an allergy to milk or cleaning products, but it turned out to be atopic dermatitis. And from that moment, my entire childhood was about trying to find the cause of my allergy. So the pillow, house dust meat, the milk, the eggs, the gluten, the peas, yes, even the peas because of a positive IgE blood test, the dogs, the cats, the shirt, the grass, indeed, the life. I went to more than 10 doctors, from dermatologists to allergists to homeopaths, and tried different types of treatments, from conventional to spiritual ones, and they all helped me for some time, but invariably at some point the pruritus and the lesions would come back, again and again. At that moment, in my teenage years, I didn't really know what I had, and I remember 2 things remarked me a lot at the time. When people used to ask me, what do you have? Then I remember saying, I have an allergy. Then they invariably replied, but an allergy to what? And I said, to life. And the second point, when I had to fill out a questionnaire that asked, do you have an allergy for an exam or for anything? I didn't know what to answer, I got lost. At that point, I was at the peak of my adolescence. and it has some points that bother me a lot. First, during the consultations, my mother was the only person who spoke. She thought she knew if I was satisfied or not, how I was feeling, and the doctor just agreed with her answers. The second, I felt like a terminal patient. You can't go to school like this, you can go to the beach like this, you should stop playing soccer, the sweat worsens your allergy. I noticed very soon in life how my AD impacted her, sometimes even more than me. So I had to hide some things from her because I knew that would make her feel bad. And last but not least, I spent all those years with that famous phrase, "It will get better when you get old." A mantra that became a bad karma for me because, as you can imagine, it didn't. So, what was really happening in my adolescent mind during that period? Of course, I was listening to everything they said. Jokes apart, that lead us to the second chapter, and now I will talk about changes that happen during adolescence. But I will not focus on physical development. I will focus on the brain changes during adolescence, and especially about 2 points. There are some specific changes, and especially this misbalancing between the limbic system and the frontal lobe. The limbic system, especially the amygdala and the hypothalamus, develops first, then frontal lobe. And frontal lobe, especially the prefrontal cortex that regulates our planning and control impulses, develops later, until our mid-20s. And this explains why sometimes teenagers can be moody or have emotional outbursts. And beyond these specific changes, there are global changes that are happening in our brain during adolescence. Worth saying the synaptic pruning, or we could say cutting weak connections. The brain volume really shrinks, and that allows the bodies to focus and use resources on the connections that are used most, to be more efficient. But a kind of scary implication of that is that what we do during our teenage years might be literally shaping our brains for the rest of our lives. It's kind of a use it or lose it principle. So if we spend our free time reading or playing sports or focusing on academics, then that's what's going to be reinforced. The parts of the brain that are responsible for those behaviors are literally going to be strengthened. But if we spend our time in the couch, watching TV, or procrastinating, then that's going to be strengthened instead. That's why advances in neuroscientific understanding lead us to think that adolescence is more than just a phase of life or a period of risk. It's a period of unique opportunity of development. And that leads us to the actual behavior of family members and the patients. We all recognize a mother or a father of an atopic patient at the moment that she enters the room. Overprotective, they put the child in a glass dome. They think that by avoiding places, foods, and new experiences, their kids will be safe and will get better. They don't do this for bad. They're often feeling guilty for their child's disease and suffering. Also, they receive a lot of criticism for their parent skills from relatives and society. And the patient, always quiet but watchful, has to deal with not only physical discomfort, social challenges, and sleeping disturbances, but also with his adolescence, being from a phase of new discoveries to a life that he is constantly being observed. To illustrate a little bit of the patient's need, in this study, 117 young adults with atopic dermatitis were asked to report their personal needs during their course of life with atopic dermatitis. 87% of the patients reported the need to receive clear information about the treatment of the disease. 85% report the need to receive greater empathy with the doctor. 68% report the need to receive psychological support, and 52% they need to deal or to share experiences with other patients with AD. And that last point comes to my last part of the presentation. For that, I will talk about my experience along with Dr. Takaoka and the AADA. AADA is an association of support for patients and families with atopic dermatitis. There, we hold monthly meetings with patients and families. I started participating in these meetings 2.5 years ago when I entered the residence program. Before that, I didn't have much contact with other patients and families that suffered with the same disease as I. The same as the majority of AD patients don't have this experience, despite it being a very common disease. And to my surprise, since the first meeting, to each family that I heard sharing their experience, I saw my own story being told, word for word. The exact same problems, the exact same path traveled. It reached a point I got scared of the resemblance of each and every family. The overprotective mother, the faithless father, the introspective and shy patient, that incessant search for the guilty, for the villain, for the miracle. The family's world turns upside down and begins to revolve around the AD. Children spend their lives trapped at home. After all, they all had an allergy to life. Don't eat this, don't do that, don't go there. In these meetings, there are families that have been coming for years, and new ones. And the intention there is not just for us health professionals to talk, but for us to conduct the session and to let them interact. And the coolest part is that it seems like they understood the brain's development in adolescence without really studying neurobiology. The more experienced families help the new ones to deal with that huge anxiety. And there is one advice that every family that have to deal with AD invariably has to understand and understand. That is, just let them do. Let them try everything they want, let them go everything they want, let them do everything they want to do. Let them fall flat. Sometimes, even if this thing is known to be potentially prejudicial for AD, let them see for themselves. Exact the use it or lose it principle. And that brings us back to the last part of my story. I will be short and I will be brief, and in short, my AD didn't heal and also started in the face. When I was in medical school, it continued the same. I tried some systemic treatments and also had one hospitalization during this period. But despite all this path, my life was more than that. After all, I went to a great university to study medical school, and I'm studying dermatology at the best university in Latin America. And beyond that, I have had one great teacher, a teacher that my father, as a physical education teacher, and my mother too, I must be honest, never let me stop. The sport. I did a lot of sports during my life, but as a good Brazilian, I always played soccer. And inside the field, there was only one thing that matters: who plays well. Of course, sometimes the boys asked me, or even joked because my face got red after the games, or because I scratched myself a lot during trainings. But inside the field, there was no AD. I was equal to everyone, and I had to rely on myself if I wanted to achieve something. And modest aside, I must admit that I played quite well, and that gave me the confidence to have social relations with my peers in school. And I have a much better adolescence than if I had just stayed at home. Sports made me friends, made me believe in myself, and made me aware that I wasn't the AD. I was a guy with AD. Finally, I want to leave some final messages. First, we all have the obligation to put the teenager in the center of his own treatment. We have to be sure and not to presume that we, or their parents, know what's really going on. And given the adolescents, this responsibility is a good way to achieve that. Second, we have to remember that adolescence is a period of unique opportunities of development. We have to remember the use it or lose it principle. So we have to take the weight off the shoulders of the parents and encourage them to let their children live the most normal life as possible. Third, the physical treatment is mandatory, but very often the patients and their parents need psychological support. And sometimes talking to families that are dealing or have dealt with the same situation can be more effective than just a long talk with the doctor. And that, despite the AD sometimes giving it a show and saying hi, they can dream their dreams and do everything they want. Thank you.
Obrigado, Leonardo. Thank you very much. It was really great presentation. So I think we're going to open for questions. So anybody has any questions about these two presentations? Please don't be shy. I think there's one from, yeah.
Leonardo, it was excellent presentation. I congratulate to you. And if you have any problem, will you have any problem in Brazil, my clinic in Gdańsk is opened for you. We have doctors from Belarus, Ukraine, but not from Brazil. You will be the first.
Leonardo, senta aqui.
Hello, good morning, everyone. Thank you for the presentation. They were very, very insightful. I'm Dr. Folakemi Cole from Nigeria. Regards patient education, recently we started using online platforms because we find that we're able to reach a large group of patients. So for some conditions, we have a WhatsApp group, and there we can provide information for our patients. Sometimes they ask questions. It's a bit cumbersome, but I think it's helpful. I don't know whether that is something that is possible here, whether there are limitations or regulations to doing that with regards to patient confidentiality or any other possible policy constraint about that. But we find that having WhatsApp support groups for patients is really helpful with therapeutic patient education, and you're able to reach a large number of patients, at the same time, rather than just, the one-on-one TPE. So I'd love to know what your thoughts on that are. Thank you.
Thank you for your experience. I think during the last COVID period of time and during the last two years, a lot of atopic school finally stopped and tried to use electronic means to obtain to train the patients and with the doctors. The experience is not, it depends. The experience is not only positive, but not only negative. So I think probably in France it's the problem of the distance between the hospital and the patients is less important than in your country, maybe. So I think it's easier to have to create a session dedicated to education using telemedicine. And I think we have to learn about your experience, not only from you, but also from other countries in Europe and in Africa.
I would dream of having the WhatsApp with my doctor, but of course it's not possible. Some of you know my doctor, it's Carly Paul from Toulouse, France, and he's a very nice doctor with a nice team, as I said, but he doesn't have the availability. And what I try to do as an expert patient is to create content on internet and social media through little videos, through little posts to spread the message from therapeutic education. And I think there is really something to dig here, to find ambassadors and patient advocates that can spread the therapeutic message. And from for the other patient, we have what I call street credibility, and it's really helpful when the message doctor go through our voice. It's really more powerful. So not a WhatsApp group, but I mean some content on social media and on internet can really be helpful, and some support group via internet can be really helpful.
My work for conclusion in dermatology residence is about creating a pilot of a online educational project for patients with atopic dermatitis. And we are creating this project in the University of São Paulo. And the patients comes from a very poor area. And at first we thought if they would be able to connect and to participate in this meeting, but we saw that they were able, and they share their experiences, they can connect, and we have no problems related to that part. So I think it's one really good way to help the patients without being impersonal. But after this, I talked to them and I asked, what would you like to recommend for us if you have to change something, expecting some counsels for by the patients? And what they said is they would prefer to do it in person, most of them.
Yeah, there's one thing about having WhatsApp groups, for example. I think it's very important to have a professional, health professional in any group. Otherwise, patients will just talk within the group and exchange treatments, for example. It's very common to see used to be more common with Facebook, for example, but now it's WhatsApp. And if you just have patients talking to each other, they will start, exchanging treatments. They said, I just have to use this cream, it's great for me, why don't you try it? And those things we of course don't encourage people to do. So it's very important to, if you form a group, you have to have healthcare professionals inside the groups. So I think unfortunately we have to move on because we have constraint of time. Thank you very much for your participation. Thank you very much. And I would like to invite Professor Peter Schmidt-Grendelmeyer from Zurich in Switzerland. He's going to moderate the last session. Thank you, Peter.
Thank you, Roberto. First of all, I would like to congratulate you and Jean-François for this excellent session. I think you have put together a wonderful program. And also to Fanny for this very nice discussion. And Leonardo, deep respect for what you did, how you presented. You should make a video of it and it should be globally sent because it was so touchy, so well presented, really. So then it's my pleasure to hand over to the next session, which of course goes into that area that we've just seen, patient-doctor communication, a truly important fact. Not the only important fact, but very important. And we would start with the presentation from Enrique Ishii, also from Brazil. He will speak about what are the expectations of patients. Of course, something which is always very important. Thanks for taking all the way to come here. And please, the floor is yours.
Okay, thank you. First, I'd like to thank ISAD and Professor Stalde and Dr. Roberto for inviting me. And I'll start by, okay. Well, I'll talk a little bit about myself. It's a lifetime ago. I was diagnosed with AD 40 years ago. And I remember, even today, I think I remember for all my life. The doctor in charge looked at me, pointed at me, and said, "You are an AD patient." I wasn't aware at that time that was not just a diagnosis, it was a curse for the next years, because most of my time my case was mild to moderate. But for a period, it was severe enough for me to have to be hospitalized for a month. And at that time, about 35 years ago, a doctor asked me what the patient wants, what their expectations. And I told him, I want the cure, we want the cure. But it was 30 plus years ago. And I had the chance and opportunity to talk to other patients, first in Brazil, in the support groups. And then later, I had the opportunity to go to other countries and talk to other patients from several countries, like the UK, US, Canada, Spain, Malta, the Netherlands. And talking to these patients with their shared experience, and some words start to pop up. Not on my life, but those patients too. I think everybody knows what these words are. Not just what the symptoms the patients have, but I think the complaints they had about the treatment, the effectiveness of treatment, and even complaints about how the doctors used to talk to them. But that's just my opinion and the opinion of other patients. But then, well, Dr. Dar also talked about AADA, the Brazilian Association of Patients and Healthcare Professionals in Brazil. And a survey was conducted in 2010 with 200 people interviewed. And the main question was about the satisfaction about the treatment. And 80% of them said they were not satisfied about the treatment. From then on, I saw there are other scientific studies trying to understand, trying to talk to listen to the patients, not just the consultations, but about their expectation about the treatment, what they thought about the treatment. For instance, this study in Poland in 2016, mainly with children up to 12 years old. And the authors find that almost 60% of them, 55% were not satisfied with treatment. And also there was a lack of adherence to the treatment. And the patients also talked about some other issues like lack of psychological support, the difficulty in obtaining reliable information about the disease, the engagement with the treatment, and also lack of satisfaction with the doctors. Another study in Germany, there was almost 2,000 patients. They asked about what they wanted about from the treatment. And again, the main answer was about the itching. Almost 100% of them wanted to have to be free of itching. Another study involving more countries in Europe and even Japan, also with almost 2,000 patients. Again, asking patients what they wanted. And the main answer was again about itch. The second was related about healing the skin and sleeping conditions, and some also address having pain due to the disease. And finally, also in a study in the United States, also talked to patients. Except the study in Poland, all of the other studies were made with adult patients. And again, the American patients considered the answer that itch was the main issue related to atopic dermatitis. Then my opinion about what the patient wants has changed over time. Of course, I want the cure. I believe all patients want the cure. But as it has no cure, at least for until now, what can we do? What do we expect for the treatment? First thing, itch reduction. Maybe it's the main expectation we have about the treatment. Skin clearance. We want to have a skin free of lesions. We think about quality of life, just like sleep, in some cases, not having pain because of the disease. Psychological support was also mentioned for several patients, not only about from the doctors, but also about their lives and how they can cope with the disease. And finally, maybe the most important thing is the patient-centered decision-making. Maybe just semantics, but I always thought that we should, there's a like relationship between the doctor and the patient. What we have to do is to treat the patient, not the disease. I think the patient is the main focus. And there was one of the main complaints I always heard from other patients. We go to the doctor, they see us, but actually they don't see us. They just see a case, a file number, they read our medical record, they know they prescribe a medication, but they actually don't listen to us. Like Fanny said in her presentation, what we consider severe is not necessarily the same as what the doctor considers severe. And both are right, actually. But it's important to understand what the patient wants. And for understanding that, I think maybe that's the main expectation the patient has, is to be heard during the consultations and during the whole treatment. That's it. Thank you.
Thank you very much, Enrique. Do you have questions or comments for his statements?
No.
Or maybe at the end when we do the roundtable.
Okay,
thank you very much. Then I would like to invite my co-chair somehow, Professor Jean-François Stalder from France, who has worked a lot on the patient education, but also scores and so on. Now he will speak about something which is moving in more and more, digital tools in personalized eczema management. We are all excited to hear because every one of us tries to put that into daily life. So we are looking forward what you will present us, Jean-François. Please.
Thank you very much. I think this topic is probably one of the more actual topic. But at the beginning, we have to say that finally, the patient suffering with AD, they mostly express their disappointment in the management of their disease. That is global, not only in Europe, but also maybe in other parts of the world. And especially maybe due to the discrepancy between the need expressed by patients and their family and the reduced availability of the doctors, which is a major factor. So this factor affects both in developed countries and countries with fewer medical resources. So how to respond to the essential needs, knowing that in the same time they are easy, accessible, affordable, and inexpensive means of communication. I would like to show that a group of international experts, patients, and healthcare professionals named OPEN, a lot of them are here in this room, and this OPEN task force, Open for Oriented Patient Education Network, has been committed for almost 20 years to patient-centered approach, also called therapeutic education. So despite the recent, so the new digital application I will show you will serve as an illustration to show the issue, the limits, the needs, and the perspective of these new personalized digital tools. Using a digital tool in eczema care, if you use Google, you obtain rapidly more than 27 million hits in this field. So it's a very huge program. So we have multiple teams, and probably we have to be sure that in this team of global digital tool, we can use different terms. So multiple terms for about this point is we can observe generalist information of eczema, how to recognize it, what is the cause, how does it evolve. That is only information. So you can find it on on many websites or social media. How to assess the severity of the disease and what you assess the impact on the quality of life. That is the second subject. And finally, which new treatment also. And if you have a critical approach, in fact, only few applications have been created based on the real needs expressed by patients. So let me show some successful application, because among this huge number of applications, I selected, I apologize for the experience I forgot, but let me show use successful applications. The first example is Eczema-Wise. Eczema-Wise is a new applet from the National Eczema Association. Eczema-Wise activate patients and caregivers in their eczema care, enhance shared decision-making between patient and healthcare provider, and advance eczema research through a novel real-world data. Eczema-Wise, thanks to this powerful association of patients in the United States and the active collaboration of many experts, doctors and caregivers, that is a successful example of what the computer tool adapted to the care of atopic patients can bring. With the example of management of AD, treatment regimen, recall information between HCP visit, illustrate shared decision-making, enhancing outcomes, and finally, obtaining data directly from patients in real life, which bring useful information. Another example is the POEM app. POEM, you know, everybody know. POEM is a patient-oriented measures developed by the Nottingham Group. And POEM can be completed now electronically on My Eczema Tracker. POEM asks you 7 questions to help track eczema symptoms, and it is a tool for using for monitoring the subjective symptoms. POEM was recommended by Home Initiative for measuring patient-reported outcome in eczema trial. So what news about this application? So POEM was used in 2022 in an experience of Kim Thomas group from Nottingham, published in the British Medical Journal, was used to determine the effectiveness of 2 online behavioral interventions, one for parents and carer, and one for young people to support eczema management. 2 independent, pragmatic, parallel groups were randomized, and online intervention provide, at the end, an evidence-based support for eczema self-management, led to useful, sustained benefit in eczema severity at over 6 or 12 months in children and young people. So the last example is PO-SCORAD. Everybody knows PO-SCORAD. It's a validated patient-reported outcome developed by the European Task Force on Atopic Dermatitis 20 years ago. But now we had many applications and many use of this application. PO-SCORAD takes care of objective and subjective symptoms, and PO-SCORAD application allows the patient to self-access, taking into account their age and also their skin color. So I don't know if you know the SWOT. SWOT is a marketing tool, and finally we use it after 10 years of use of the PO-SCORAD applet to reevaluate these PO-SCORAD applications. SWOT is the acronym for strength, weakness, opportunity, and threat. Finally, among the strengths, the notion of validated expert, translation in 24 languages, dynamic monitoring of patients at a large scale was important positive point. But among weakness, this application was only designed by expert physicians, and the patient benefits were not clear. So seizing the opportunity of this existing international network, including doctors, patients, and healthcare provider, we decided to use a global disease process to create a new tool adapted to real needs of both patient and caregivers. So for that, we used design thinking technique. I will move directly to the technique is used as a creative design method of innovation developed at Stanford University in the United States. And for the PO-SCORAD, several international multidisciplinary workshops were carried out from 2018 to 2022, led by Roberto Takaoka and Giselle Raulik from São Paulo. Here is an example of what the concept of design thinking. The beginning by the problem, the ideas, the concept, prototyping, and finally obtaining a digital form to evaluate and finally to disseminate. So we now are at the digital platform, and finally we achieve this tool. for assessing patients. The patients can assess themselves, selecting the zone for eczema, tracking the evolution. Here is the curve of the patients can obtain, sharing with the doctor to receive personalized advice, and finally obtaining other details about the question the patient wants to ask to the specialist. So, in few words, eczema care allows the patient to prepare the consultation, to visualize the evolution of the disease, to transmit to caregivers the therapeutic response using PO score, DLQI, or Topic Up, and to obtain recent and validated information on the disease. So for the physician, he can have many benefits based on the response to the questionnaire. This observation is sent to the doctor, which guarantee time saving and better listening during the consultation. And the written action plan and the therapeutic choice can be shared with all these, the patient. This application is a scalable application, and I would like to open the discussion with the next phase. The last version is this last version will be available in a few weeks. We add artificial intelligence using eczema pred, which is an algorithm developed by a group of RAJKA Tanaka at the Imperial College of London, and obtaining a prediction of the course of the disease following the curve of the PO score. And the last point will be with the automatic image analysis, which simplifies the evolution. This last point is under progress, but some publication made by Legit Health and our friend Ramon Grimalt from Barcelona gave very encouraging results. So it could be possible to obtain a fully automatic scoring system for the severity assessment using image analysis. So at the end, artificial intelligence can help to personalize digital tools without replacing the doctor. AI offers appropriate advice to personalized adaptation. AI makes possible to fight against isolation by helping the patients to become autonomous. I think about patients living maybe in Africa. And ethical constraints, however, must be heard and respected, even if the legal aspect is often delayed. So at the end, let me first thank all those who participated in the creation, development of this tool, from the member of the Open Task Force to the patients who have joined us. A word also for the Eczema Foundation, without which we could not have carried out this project. And finally, just I can say that the report of our exchanges, the global exchanges, will be published in the journal GEDV, Clinical Practice, in the form of an easily downloadable video clip. So, thank you for your attention.
Merci beaucoup, Jean-François. for giving us insights in all these developments. We will also discuss it later. Yeah. The next presentation somehow is adjacent what you presented on artificial intelligence using digital tools, as we'll have a video from Professor Peter Leo from the United States, who will show us the possibilities of ChatGPT in atopic dermatitis. Maybe used ChatGPT for whenever booking a ticket or something. So we are very excited to see what it can bring into AD. I don't know if technically we are already ready for the video. It's already.
Hello, I'm Peter Leo. I'm a clinical assistant professor of dermatology and pediatrics at Northwestern University, Feinberg School of Medicine in Chicago, Illinois. I'm also the founding director of the Chicago Integrative Eczema Center. And I've been interested in this interface between technology and medicine for a long time. So it's with great pleasure and a great honor to be here to present a little bit about artificial intelligence in atopic dermatitis. I think this is one of those areas that we will look back and say, wow, 2023 was an incredible year because everything sort of changed. And we're going to go through a little bit about why I think it's been such an exciting time. These are my disclosures. And I'd like to start with this quote from Schopenhauer. Quote, "All truth passes through three stages. First, it is ridiculed. Second, it is violently opposed. Third, it is accepted as being self-evident," unquote. And I really think that we are entering into that second phase with artificial intelligence. We're seeing some of this violent opposition, but I do think we're heading towards the third phase, that eventually we're going to say this is here to stay and we're going to have to make the best of it because we've opened up a Pandora's box. The history of artificial intelligence in medicine goes back a long way. It really started in the 1950s when mathematician, computer scientist Alan Turing talked about this simple test to determine whether computers were capable of human-like intelligence, and this is now referred to as the Turing test. We know that in 1956, John McCarthy first coined the term artificial intelligence and defined it as the science and engineering of making intelligent machines. So we've had many decades to think about this idea, but it wasn't until very recently that I think it became almost uncomfortably real. And things have gotten quite interesting in the last couple of years. Now, what we're talking about with artificial intelligence is pretty broad. I think it can mean many different things, but specifically I'm focused on these large language models, or LLMs. These are really concepts that are similar to predictive text input. You know, when you're typing in a text message, it'll tell you what it thinks the word is going to be. It is a cousin of that, although it's much, much more sophisticated. And the one I think that is sort of leading the pack right now, and this is of course an ever-changing science, things are changing honestly daily, but the one I think that is most in the media right now is called ChatGPT, and that stands for Chat Generative Pre-trained Transformer. But there are many like this, as we'll see in a moment. And what's exciting is these can really become a source of information for patients and caregivers beyond, of course, everybody else. I mean, it's really everybody's using them for different things, but we can use them in medicine as well. And ChatGPT specifically is a conversational chatbot. It's been trained on a huge array of internet sources. Now, it's important to know that it learned from the internet, so there could be things that are false or incorrect in its database, and that's important to know. But the good thing is it, in theory at least, can use reinforcement learning and is constantly being updated. In fact, I just saw a paper just in the last day or so where they were comparing in the last few months that there have been changes, some for the better, some for the worse. And so I think this is something that is in flux, and that also makes it difficult to study because it's not like we're querying a database. If you say, you know, what is the answer to this question? You say, oh, well, it did a good job or it didn't. You could ask it again 5 minutes later and it could give you something quite different. So this is really important to understand these limitations. Whatever you think about this, there is tremendous growing interest. ChatGPT surpassed Instagram for the fastest growing user base, 1 million users within the first 5 days of launch, 100 million users by January 2023. So there are a lot of people talking about this, thinking about this, and now using it. Of course, this is being adopted by a number of companies, Google, Microsoft, Quora. They're all working on their own versions of this. ChatGPT is just one of the many. And of course, even Apple, I just read a rumor that says they are working on their own version of a ChatGPT type artificial intelligence. So this is going to be a very interesting time to see. And part of my interest is comparing them and contrasting them and seeing which one does better at what. So far, my own experience, and again, this is very limited to my experience, is that ChatGPT seems to be the leader. It gives me the most consistently interesting, robust answers. And we've written a couple of smaller papers recently comparing, and some of them won't even engage. The one that's currently part of Google's website is much, much more conservative. It often will not opine on anything we give it. So it makes it more tricky to study it. Now, one of the most fascinating aspects of this ChatGPT and of course, artificial intelligence as a whole is that it can make some interesting mistakes. So the thing I was really introduced to first was the ability for it to render artwork. And this particular image you're seeing was rendered in a software called Midjourney. So there are a number of these out there, these AI kind of rendering programs that can actually design images for us on the fly. So Midjourney is one of them. And here the prompts were a patient who has eczema and is extremely itchy, scratching up their skin. And this is what it generated. It's a beautiful kind of a painterly image. It looks almost like a classical painting, a Norman Rockwell painting. We see bloody areas on the belly. It looks like it's all open and oozy. This is amazing. But I want to point out something I think that's beautifully illustrated here. Let's zoom in on those hands. And when we do that, we see something kind of strange. There are more fingers than there should be. This is a mistake. And this is a known issue with artificial intelligence generated images, that they can often have these strange errors, these weird discrepancies from reality. And this is important because this is a visual illustration of something that also happens in the chat or in the text-based world. And this is sometimes referred to as the confabulation problem. It's lying. Well, lying might not be the best term because I don't think it's malicious. Its intent is not to deceive, but it's hallucinating, another term for this, where it's seeing things that aren't really there. And part of the problem with this is that in attempting to sound so human, it tends to sound equally confident even when it's unsure. It doesn't ever seem to feel unsure. And that's very different than when you talk to a human, even an expert. They might say, well, look, I'm not so sure on this part. Can you check this? Or I don't know. I'm going to hazard a guess. But it doesn't speak that way ever in my experience. So it can make it very difficult to know when the answer could be untrustworthy. Now, from my standpoint, asking questions about atopic dermatitis, it's easier for me to see when there's a problem. Or, as I experienced not too long ago, it brought up a couple of references that I said, oh my goodness, these are amazing. How have I never come across these? And so I started looking up the references and I couldn't find them. And it didn't take me long to realize that these were fabricated. There's no such thing. I even went to the actual journals I searched through carefully. They were made up. And that is a little scary. And of course, if you're not an expert or you don't have additional resources, you might just assume it's always correct. Well, this has been illustrated writ large in a beautiful case scenario that just happened, beautiful and terrible. A federal judge has just imposed fines on a law firm in a case where they actually used ChatGPT to create this briefing, and it made up fictitious legal research. The judge said the material generated by the chatbot has, quote, some traits that are superficially consistent with actual judicial decisions, unquote, but other portions contain gibberish and were nonsensical. And this very much reflects my experience when I was using it to do something very scholarly. It seemed so correct. I mean, it was remarkable. This is an example in the real world how it's caused trouble. That being said, day to day, it's almost magical. So I recently asked it to write a sonnet about eczema in the style of Shakespeare. When skin doth flake and itch with fervent rage, eczema's cruel touch casts shadows deep. Upon the flesh it wages war and siege. In sleep's embrace its victims cannot sleep. I mean, that's unbelievable. It just made that up on the fly. This is not pulling from any source. It truly created this. It's incredible. So these types of generative concepts are amazing to us. And again, can be borderline magical. You can ask it to do things like write music. And it can't necessarily play music at this point, but it can give you musical chords. It can talk about music. And of course, then that brings us to the practical aspects. We can ask it a hard question like, can I get the shingles vaccine while on dupilumab? A really important question many of my patients are asking every day. So I love the idea that we have something here that can actually give us an answer. Now here, I think the answer is beautiful. It's well thought out. It's balanced. It really gives the principles as well. I would argue that this answer right here, and you can take a minute to read it if you like, I think that it is every bit as good as something I would write back to a patient, and honestly better. And then, of course, that last paragraph is really important. Your doctor who has a comprehensive understanding of your overall health and medical history is the best person to provide advice on whether you should receive the shingles vaccine while on dupilumab. Amazing. So I think it's fair, it's balanced, it's cautious, it's wonderful. It's really wonderful that it would do it this way. And so seeing this, you might think, well, is a computer, how can it be empathic? How can it actually give the kind of responses we'd expect from a human? And I'm happy to say, or maybe scared to say, that it can. And in fact, a recent study evaluated the ability of ChatGPT to provide quality and empathetic responses to patient questions that were posted on a social media forum. And they compared this to that of a physician, and they found that ChatGPT responses were rated significantly higher. It was better in both quality and empathy compared to the physician responses. So this really does suggest that AI is going to be useful to us. And I would argue that it couldn't come at a better time, because we are overwhelmed, or at least I'm overwhelmed, and a lot of my colleagues seem to be overwhelmed. There is so much involved in patient care. You know, taking care of the patient, that moment in the room is magical, wonderful. That's my favorite part. But that is only a fraction, a sliver of what we're doing for the rest of our day. And in fact, a recent paper found that clinicians were spending on the order of 5.5 or almost 6 hours of an 11-hour workday in their electronic medical record every weekday. And I believe it. I mean, I'm constantly on the computer. Inbox management. Now, this is the key piece. Managing these messages from our patients, right? Now, typically these are not billed, at least in the United States. They're not a billable concept for the most part. And they're a wonderful idea. I mean, how nice is it? A patient can just simply shoot off a quick email and say, Doc, I have a quick question, or I want to give you an update. It's a beautiful idea. And there's no doubt that it seems like it should be part of healthcare, but there's not really a structure for it. There's no time allotted for it. There's no money allotted for it. So it becomes this extra piece. And if it were just a few minutes a day, I think we could say it's no problem. But here in this paper, and this is back in 2017, it accounted for 85 minutes per day. And I totally believe it. I mean, I spend at least an hour a day on messages, sometimes more, to the point where it's overwhelming. It's just not a sustainable thing. I don't know how we're going to keep this up. And it's something that is also, of course, growing, because as more patients become comfortable with it and expect it, especially after pandemic, we're in some trouble. So we're going to need some help, and this couldn't come at a better time. But what can we expect? You know, is it going to continue to do that for our patients? We've seen some good examples, but what would happen? So we asked ChatGPT-4, the most current up-to-date model, 100 questions that we culled from a list of common questions. Now, I want to be clear, we didn't pull from any record, we didn't pull from the patient actual questions, but we just used the same questions that we see on our inboxes and on our patient forums where patients are asking these things, and we put them into ChatGPT and we asked them, why 99? Well, we asked 100, but there was a duplicate in there. We accidentally duplicated one. So it was 99 individual questions. And then we copied and pasted the response that ChatGPT gave, and we put them in a spreadsheet, and we had 11 international dermatologist experts in therapeutic patient education rate them with a Likert scale. How did it do? And also, of course, flag anything that was worrisome. And the paper is submitted, so I don't want to give any spoilers yet until it's out, but I can give you a little preview that, as you can imagine, it was pretty darn good. It did a great job. Now, this is an example of that, and this is not from the upcoming paper, but here's one where a patient asked me the other day, my 4-year-old child has eczema. How often should I give him a bath, right? This is a key question that comes up all the time. And I think ChatGPT did a beautiful job. It first starts out by saying, I'm not a doctor, but bathing can play an important role in managing eczema for many people, right? It gives this nice sense of understanding. It talks about what it can do. It can help to remove irritants and allergens from the skin. I love this idea. Hydrate the skin and provide an opportunity to apply moisturizer. So then it goes through and talks about some of the different aspects. I think this is an incredible answer. I love this answer. I would give this answer a 10 out of 10. Honestly, I'd give it an 11 out of 10 because I wouldn't even write all this to a patient. Can you imagine how wonderful is it to get a customized message back to a patient instantly? Another one is tacrolimus safe for my child's face? This question comes up a lot. The other day I had someone asking this question, and what had happened was I had given them an eczema action plan. We talked about everything. We wrote everything out, and they went to the pharmacy to pick it up, and the pharmacist says, ooh, I wouldn't use this on your child. This is dangerous. This has a black box warning. And they were very nervous about it. But here, ChatGPT writes a beautiful, with that's the only prompt. This is literally pasted. I didn't manipulate it in any way. It wrote all this, but look at that last point. Number 6, other considerations. There was some concern about a potential link between tacrolimus ointment and an increased risk of certain cancers like lymphoma and skin cancers. However, the FDA has stated that a definite link has not been established. How wonderful is that? So I love that it is so balanced. And I have really started to think about how can I use this with my patients, and can I get my patients to do this first? You know, the dream would be they could sort of ask it first, and ideally maybe a curated version of it that would make sure there wouldn't be anything input that could be potentially dangerous. And then if there was further questions or another issue, they could come to us. It could at least be a layer. Obviously, I haven't done this yet. We can't do this yet in good faith, but I think patients are going to be doing this. They're going to be searching for it, and it's out there. It's a powerful, powerful tool. So in conclusion, I think we've entered into a new era. Whether you like it or not, it's going to be incredibly exciting. It's probably going to be scary as well, but I think it's going to help us, and it's going to help our patients. It's going to have to, because I don't think we can go back. We can't put the genie back into the bottle figuratively. It's here now. And even with the most powerful government regulations, I don't think we're going to be able to stop it. It's going to be able to infiltrate every aspect of our life. And I think the only way to approach this is with some enthusiasm, optimism, and humility, because we know that we may have unleashed something really powerful, but this wouldn't be the first time we've done that. On that note, thank you so much for your attention. I hope you enjoyed this, and I look forward to seeing everybody soon. Take care.
Thank you, Peter. Due to the time changes, he's not able to enter into the discussion. But maybe first, I would like to ask the audience, who has already used ChatGPT or something similar? Oh, at least half, if not more. With this, I would like to open the discussion. Maybe, Jean-François, I would like to start. You were mentioning from the SWOT, S-W-O. Do you also see T, threats?
Oh, yes, about threats, but I think the difficulty, maybe the threat of P-score will be to be an other score, but without any benefits for patients. So it was maybe a null approach. So that is not exactly the case in the P-score. We use a SWOT because the SWOT is very well known. But finally, the risk of threat is not very important. And we finally use the risk of the SWOT is only for taking into account we have to modify maybe every 10 years our approach, because if we do not do that, I think it could be difficult to follow, not only to follow, but to obtain the participation of people, and not only doctors, but also especially patients. Because the patients know very well. When you ask the question concerning GPT, I think a lot of people were patients. I think probably more patients than doctors. So the reason why we have to adapt ourselves. And the question is not to offer a new model, offer a new perspective. It's really to follow the needs of patients.
Enrique, I would like to invite you to tell your expectation from digital tools for a patient. Maybe you come again on the stage. As you mentioned, what are the expectations? What is really a help?
Well, I think any tool that will help patients to understand how to cope with the disease really will be nice. My only concern is, I think that Dr. Lara has told about his experience, the patients using the app, or they prefer to talk. It's easier for us to talk to the doctor, but the patients at the end of the day, they rather prefer to talk face to face. But I think, like Dr. Leo said in this presentation, this technology is here to stay, and we cannot avoid it. The best thing I do is use the best of it and control how to manage. But we have to accept that it's here, and maybe so. Like Dr. Professor said, many patients will be used maybe even more than the doctor. I think it's a welcome technology.
I would like to open for questions and comments to the audience. Anyone would like to comment? Yeah, Usman, please.
So thank you so much for this interesting talk about artificial intelligence. So I have an experience using ChatGPT in our setting. So it's a very amazing story. I mean, about 1 month ago, one of my colleagues asked me about ChatGPT because I was wondering, because I have a topic to give in the next meeting of ISAD. He told me, do you try ChatGPT to give you some idea? I said no. So, you know, he also continued to say, you know, all of your residents are using ChatGPT because the last evaluation you did for them, they try later on ChatGPT, and all the response about that question were on ChatGPT. So since then, I continuously using ChatGPT because from now, our patients are in advance on a doctor because we are less using this artificial intelligence because we already wondering whether this machine will replace or not doctor. I mean, as a doctor, we are afraid about using, so you must use it. That's my experience with artificial intelligence. Thank you.
Anyone would like to comment? I totally agree with you. I think it's your experience is an exemplarity. I think I discovered ChatGPT during the last American Academy meeting, and when we were with our colleagues at the open meeting, and finally we decided to launch this trial. And I don't know if we will be able to publish the paper, but it was really interesting because we were impressed by the response given by ChatGPT, which were more precise, with less anomaly, less than compared to classical Google research. So if my feeling is maybe patients could use ChatGPT, it could probably be less dangerous for them than to go maybe to certain social media, because sometimes it's difficult. But I agree with you.
Yeah. There's one more question. Oh, Fanny.
Thank you. It's not really a question, it's a reflection, but of course we are, as patients, searching for reliable information, and it's not the case yet, but at one point those artificial intelligence will be able to select the most reliable information around AD, and at one point it will be in a way helpful. But what I found very interesting and funny, if not sad in a way, is that the ChatGPT has more empathy when answering the patient than the doctors. Come on, let's make an effort.
Sorry, let me speak about empathy. I read this paper also very accurately, and finally the empathy was not really defined. So it's a global term, and I'm not sure that it corresponds to our definition of empathy as a clinician.
Yeah, I think sometimes the ChatGPT can express better, as Peter showed. He can express all the things that we think in a better formulated way.
Yeah.
just have a comment that a patient who is also a computer engineer told me in Brazil, and he's really involved. He has a company who develops chatbots, and he's very skeptical about it because he thinks this is kind of hype phase that we're going through. It's a pity that Peter cannot be here, but whenever you talk about the machine being more empathic than the human, that's a problem. So we have to maybe let things pass and reevaluate what's going on. But of course, it's like he's working with machines, and so he probably knows a little bit more than we do.
There's one on the very left, Michelle.
Thanks. I was just going to mention with the large language models like ChatGPT, one thing that maybe we could do as providers to assure the quality of the information is to maybe provide some framework on, I think, how to search, because you can, for example, in ChatGPT, you can say something like, using scientific publications or evidence-based literature, what would be, and the same kind of questions that Peter had on the screen, and that might give less risk of getting some of the fake publications out there, or the six-finger drawing kind of idea. So of just finding ways, maybe that's something that we could help with, is how to curate the data a little bit better, or curate the search methodology.
I think we could improve our use of ChatGPT. Thank you for your suggestion.
Any more comments or questions? Yeah, please, Amy or Fanny, first.
I was just going to ask, because this is a session focused more globally on AI, to go beyond ChatGPT. I'm just wondering what experience there has been or is being developed right now to use other technologies to help patients. For example, one of the most common things that clutters up my inbox are patients who are sending pictures and asking questions. For example, is this infected? Do I need an antibiotic? These kinds of things that I'm looking at. I'm not a computer, but I'm looking at them, and I'm instantly making a decision, but it's taking a lot of my time. I know, for example, we've been working with AI to develop tools to identify squamous cell carcinoma in epidermolysis bullosa patients. Can we help with some of these recurrent questions that require a set of eyes, but probably could be just as well done if we can train a computer to recognize molluscum or recognize Staph aureus infection, and make our lives a little bit easier by some quick answers for patients?
Would you like to comment? Or?
No, I think it's a very good idea.
Yeah.
Very pertinent idea.
There are some actions, like, for example, the Passion Project is putting in thousands of pictures to learn the computer to discriminate between eczema, psoriasis, infection, things like that. But it's a long way. I think the computer needs many more pictures to learn it than we have.
I mean, we've done a lot of that, but the problem is, it's so global, and we're just trying to sort these out. But I think doing a little bit more with simpler questions, there's no problem getting 1,500 images of Staph aureus infection. Each of us has that. I mean, I just think maybe as a group, we could start to think about some of these simpler tasks that would help patients.
But I think it gets into legal problems also, because if it gives, maybe a wrong answer, and it's not an infection, or maybe the computer will say it is an infection.
That's a problem for all of it. So you have to, what we've been finding is that the accuracy is just as good, but we've set up anything we've done as a continuing research project, which obviates the issues with legality and potentially being sued. So it could be set up in certain ways that we're actually using it, at least over the next several years, as a learning tool.
Yeah, for sure, that's very important. This is a new direction in medicine, and we should take our responsibility, let's say, to influence it, to improve it. There's another comment from Luis Postigo from WHO.
Hello, everyone. Thank you. I would like to comment about your question. WHO, we have put in place an app 2 days ago. I will show some slides this afternoon, but it has been precisely customized for just 24 common skin diseases. The database has around 400,000 photographs, and the next steps is to validate it in the real world. So I will be happy to talk to you and to any in this room who is interested in seeing it and see how we can measure if that is something useful for the real life. Thank you.
Thank you. That's a very important contribution also for on a global scale. You wanted to comment?
No, I was going to, actually I'm going to thank you for being the moderator for this last session, and we're going to conclude with some final conclusions from Jean-François.
I think it's probably difficult to conclude this very complete, open session. I would like to highlight maybe 3 or 4 points. The first, the experience reported by our are part of the needs expressed by all European and US countries. So I think it's not far from our feeling. And the shared experience with our African friend is a doubly enriching session, because first is the first time that during this organization of the care meeting, the session was devoted to a group of doctors and African patients. So I think we have to remember that. It's an important point. The second point is that we were able to listen the clear and relevant message of patients, and especially I think about Rachel Ogola, whose experience in Kenya is enlightened. She asked for a consensus or treatment of advertising of the patient point of view, that the patient could be developed and test in African countries. So I think it's an interesting way. The third one is the comparison of the point of view of the doctor and patients, especially concerning therapeutic failure. It was not a theatrical dialogue, but we have so much to learn from each other. So Leonardo discovered this excellent presentation, both with the difficulty of living with an eczema when you are a teenager, but also the possibility offered by the motivation of the teenager in the sense of innovation. And at the end, I think we begin to speak about perspective, new perspective in the field of education, electronic system in education. And I think we have to be aware of ethical problem. We have to think about ethical problem. We also have to think about how to validate the content and the result of what we obtained. But finally, probably this, at the end, I learned a lot during this session, and I would like to thank everybody, my co-chair especially, but also all the speakers who were very active And I hope we will be able to do that next time.
I would like to thank my co-chair, Professor Stalder, too, and thank ISAT for giving us this opportunity to have this pre-meeting, and wish Magdalena a wonderful ISAT meeting that is going to start at 1 p.m., I think. So we'll have, I think we're right on time, so we'll have time for lunch, and 1 p.m. we'll come back to the main meeting. Thank you very much. Thank you for being here.